My name is John Floretta, and I work at JPAL. And JPAL is the host for Clear Center in South Asia, which is the Center on Learning and Evaluation for Results. And at Clear, basically, we've been hosting it since 2011. And over the last year and a half, we've been holding kind of regular meetings to bring together people from the evaluation community to share best practices and share new methods. And so we're really happy to host our 6th M&E Roundtable together with 3IE. So 3IE is the International Initiative for Impact Evaluation. And they are a donor organization that funds impact evaluations, randomized controlled trials, and quasi-experimental evaluations. And they're also one of the leaders in doing systematic reviews, both funding systematic reviews, writing systematic reviews, and doing capacity building around systematic reviews. I'll try to give a little bit of a background of what a systematic review is. So at JPAL and at 3IE and at CLEAR, we talk about we want to move to a direction of evidence-based policymaking. And that raises the question of kind of, first of all, what is evidence? And evidence, is what we're referring to as evidence is the result of high quality evaluations, whether it be a randomized control trial, whether it be quasi-experimental with a strong comparison group, whether it be good qualitative evidence, that this evidence, the results of evaluations ultimately should be used to shape better policy. And there's a question about then how you go about doing that. So there's lots of, there's a lot more space for further high quality primary research, especially in developing countries, but there is quite a bit of research that's already been done. So how does this research then translate into policy change and better practices? And we have to admit that there's a pretty high cost of going through all of the primary research, assessing its quality, and then trying to derive the lessons out of that. So if you're sitting, say, in the Ministry of Education, in a developed country or a developing country, and are trying to understand what are the good practices that I can use to shape my policies, it's a very high cost to do that systematic review of evidence. So what 3IE is doing in the international space is kind of lowering that cost by providing this public good of a systematic review. And we'll get much more into the detail of what these are, but essentially it's taking a research question. Say the question is, what are effective ways to increase school participation, whether it's attendance or reducing dropout rates or enrollment, and then doing a systematic search of all of the evidence, meeting a preset criteria or a protocol in that area, synthesizing across that evidence, and then sharing the results. So what a policymaker gets is not necessarily a guide for implementation. What a policymaker will get is kind of a general sense of globally, or it can be done regionally, what's the evidence around that issue. And that can be kind of a starting point, a general starting point for policymaking. So it is an attempt to look at what works, but as we'll get into, we know it's not as simple as kind of finding what works, quote unquote. It's kind of finding which programs work, when, for who, and why. And so this process of systematic reviews, they first started in public health, then they started kind of in the environment sector. And 3IE is one of the leading organizations, together with Cochrane and the Campbell collaboration, of bringing systematic reviews to the international space. So how we're set up today is we're going to have four presentations. 3 will be from 3IE, and 1 will be from the Cochrane Public Health Satellite. And rather than kind of go through and give you the to have a presentation just on the methodology. We're going to weave in the methodology to the presentations. So Hugh Waddington, who's a senior evaluation specialist at 3IE, is going to start out with a systematic review of water supply and sanitation evaluations. And within that, he's going to cover the methodological topics of how you do the search for different evidence, and then the statistical meta-analysis. So that'll be followed by about 10 minutes of Q&A. Then the next presentation is by Birte Snilstveit. She's also an evaluation specialist at 3IE, and she's going to focus on a systematic review of farmer field schools. And within that, she's going to bring in the methodological aspects of a causal chain analysis and of qualitative synthesis of results. Then we'll break for about 10-20 minutes for tea and coffee just right outside. And unfortunately, so we're very lucky to have, so Hugh and Birte are both from the Systematic Review Office at 3IE, which is based in London, and they have flights today. So you should get your questions in for them during the Q&A, because during the coffee break they'll have to leave. Then we'll have Howard White will be the next presenter. Howard's the executive director of 3IE, and he's going to do a systematic review, cover a systematic review of education, I believe focusing on attendance, enrollment, attendance, and dropouts. And then the methodological aspect that he's going to bring in is lumping versus splitting, and Howard will have to get into exactly what that is. And so in the fourth and final presentation will be by Ruhi Saith. So Ruhi has many, many hats, and she is also one of the people, she's done many 3IE systematic reviews. She's a professor at JNU. She's also with Oxford, has been with Oxford Policy Management, and she is helping to kind of lead the setup of a Cochrane public health satellite. So Cochrane collaboration here in India. So Cochrane collaboration has been focusing on systematic reviews in public health. And so then we will then have 30 minutes for general discussion at the end. And the general discussion, so I guess let's try to get as many of the questions we can about the specific systematic reviews in the 10-minute Q&A following each presentation. And then in the final 30 minutes, we can ask kind of larger questions about the methodology, as well as any kind of follow-up questions that you might have. So on behalf of JPAL and on behalf of Clear South Asia, thank all of you very much for coming. We also have what I hope is quite a few people that are joining us by webinar. At our last seminar series, we had 200 people joining by webinar. So thank you for joining as well. And I will turn over to my colleague Sri Sen to introduce the first speaker. Sri.
Thank you, John. Before we start, I'd just like to explain the format of the roundtable a little bit. Each panelist will present for about 30 minutes. Then we'd have a 10-minute round of question and answers. We take about 2 or 3 questions at a time, and then allow the speakers to answer them before taking another round of questions. Also, at the end of the session, everyone has been given a folder, and there are feedback forms. So if everyone could fill those out and hand it back to either Priya or Rashmi. Okay. Our first speaker today is Hugh Waddington, who will be presenting on systematic review of water supply and sanitation. Hugh is an economist and manages 3IE systematic review program and the Campbell Collaboration International Development Coordinating Group. Welcome, Hugh.
Great. Thank you so much. So thanks a lot for inviting us here. Okay. So actually, interestingly enough, the field of systematic review and meta-analysis actually began in the social sciences in the United States academia, although it has been adopted by the medicine and public health. Today, I'm going to try to give you an overview of 2 main things. First of all, the purpose of research synthesis, that is taking lots of evidence and taking all of the evidence, synthesizing it and trying to make sense of it for policy. And secondly, I'm going to present the the results from a systematic review that we did on water, sanitation, hygiene interventions in controlling child diarrhea. This is a quote just for the economists in the room, and I'm an economist, so I tend to put up quotes by economists. This is a quote from Edward Leamer's famous article, Let's Take the Con Out of Econometrics, from the early 1980s, in which he's basically, the basic sense of this quote is, don't trust anything that you read in an econometrics journal. And I think that's part of the reason why we do systematic reviews. So a systematic review, as opposed to a literature review, does do, as John was saying, critically appraises the literature and all of the literature, not just that literature which is written by the person writing the review and their friends in academia. But I much prefer the way that Dean Carlin said it at a conference more recently, which is that literature reviews are like sausages. I don't eat sausages as I don't know what goes into them. A systematic review, you know exactly what goes into it. This is the logo of the Cochrane collaboration, which encapsulates a well-known systematic review and meta-analysis. The logo basically shows what's called a forest plot. A forest plot is how we represent a meta-analysis. Meta-analysis being a statistical pooling of study effect sizes to come up with an average finding across all of the studies. And so in the case of the Cochrane logo, there were studies which were assessing the effects of corticosteroid treatment on premature births, survival. And if we just looked at the individual studies using a vote counting analysis, so we basically tallied up X number of studies find a positive outcome and X number of studies find a negative or zero outcome, what we'd find is, it's not going to go that far, is it? Yeah. Okay, so it doesn't matter. So basically, if you look at these lines in this forest plot in the center of the Cochrane logo, the vertical line is the line of no effect. So and the horizontal lines are the 95% confidence intervals for individual studies. So what are the confidence bounds for an individual study? And any of those horizontal lines which crosses the vertical line is a study which shows an insignificant finding. And if we just tallied up the studies, doing a vote count, what we would have found is that 2 studies supported corticosteroid treatment in reducing mortality amongst premature births, and 5 studies didn't find any effect. And so we would have concluded wrongly that the treatment wasn't effective. Whereas if we actually treat the studies as part of a larger population of studies, taking into account the fact that 5 of the studies are clearly underpowered, and we calculate our pooled meta-analysis finding, which is the diamond in the bottom, what we actually find is a 30%, 50%, between 30 and 50% reduction in mortality resulting from the treatment. This treatment has now been rolled out, and an estimated thousands of lives have been saved. So why is a systematic review it's not a literature review? Now, frequently we get applications to our grants program. We've held 5 calls for systematic reviews so far, and many times we get in the proposals, I've done all of these systematic reviews, and generally people are turning to literature reviews. A systematic review is like a scientific literature review that follows from a study protocol in which you collect all of the evidence, both published and unpublished. So for a study of effects, it needs to be exhaustive. The audience is policymakers or practitioners. It's not research people, so there's a lot of translation work which is required. The process is very clear, so it involves teams in which 2 or more people search, critically appraise and synthesize literature, and which is set out in a ex ante in a study protocol. The critical appraisal stage is much more than you'd normally find in a lit review, so you're basically 2 people are assessing how much we trust the inferences made in the study to at least the standards you'd expect in a top quality journal, and that's then reported in the paper itself. And finally, rather than using vote counting or more scientifically null hypothesis significance testing. A good systematic review, where possible, should synthesize effect sizes using meta-analysis, weighting studies by precision, by a measure of the sample size. So here's a case in which you'll all be familiar. So we believe this is an illustrative case of why to do systematic reviews. So we all know the Miguel and Kramer paper on deworming, which found significant effects on school attendance, has been very influential. There's an international NGO called Deworm the World, and there have been large deworming programs in Kenya and India. However, a systematic review of the evidence which came out, which was updated last year, found that I'm just going to read out the quote. It's probably misleading to justify contemporary deworming programs based on evidence of consistent benefit on school attendance or school performance, as there is simply insufficient reliable information to know whether this is so. So in other words, we're still rolling out global policy based on single studies, and this is a point which Howard is going to talk about, I think, in the third presentation, which we believe is inappropriate for lots of reasons. A major reason being that that we actually need to critically appraise the evidence, and we need to collect all the evidence, not just the favourable stories, which we think supports our case. So systematic reviews. I mean, John's very nicely summarised all of this already. There's a huge amount of literature. For a researcher, let alone a policy maker, they don't have sufficient time to go through it. So we're trying to build up a library of evidence from systematic reviews. We also know that there are particular problems with published literature, which in that published studies are much more likely to be presented in journals and are much more likely to be found in the most well-known journals. So, which is why the search needs to be so comprehensive. And also, I suppose the main point is the deworming points, that the benefits of single studies, that they are context-specific, time-specific, population-specific, are precisely their weaknesses when we're trying to generalize to make more generalizable global policy recommendations. So when we do a systematic review, probably a quarter of the time is spent on searching, which does sound quite rather daunting. And you are looking through different sources of literature, so you're not just looking through the most well-known database. If it's a study on an economics topic, you're not just going to be looking at Econ Lit. You're also going through both database sources, so electronic sources, both published and unpublished, but also hand searching of print sources, websites, this kind of thing. And most importantly, and what we found particularly helpful is doing various snowballing. So snowballing includes both checking through reference lists of papers to check the literature, the historical literature, but also forwards tracking studies through citation tracking services, and contacting researchers. And we actually find that a lot of primary study authors are happy to share their results with us of forthcoming studies. Oh. Okay. In 3IE's program, and as John's already said, answering the what works question is actually part of a broader set of questions, and we are interested in knowing what works and what doesn't, and this is kind of where we started the systematic reviews program. Is the primary purpose of doing pretty much all 3IE studies need to answer a what works question, drawing on rigorous experimental and quasi-experimental findings, but the systematic reviews, they're not just going to present an average treatment effect. We care about where treatments work and for which people, and so we're interested also in the for whom and when question. Thirdly, the why question, which we've been piloting in our farmer field school study, and Birte is going to be talking about. And the why question is really the question that we believe is of relevance to the practitioners, by which I mean people designing and implementing programs. Because if a program doesn't work, we need to know whether it just doesn't work in theory, or whether it doesn't work in practice, so there's implementation failure. But there are also other reasons why we might believe a program works or doesn't, which you'll see in my presentation later, relating to measurement error. And finally, we want to know, looking across the evidence from lots of different programs, so typically a systematic review will look at just one program and it'll do a very detailed causal chain analysis of that one program. But looking across programs, what the question which Howard's going to be speaking about is for reviews of comparative reviews of effects. So which interventions are the most effective and cost effective for achieving a particular policy goal. So that's the general introduction to SRs. Now I'm going to move on to the water and sanitation study. So we should have a pile of publications. Did they arrive this morning? Yes, okay. So publications at the back, they're all free. Please take them. Otherwise, we don't want to have to take them back with us, so we'd be grateful. So this is from the WHO Global Burden of Disease, showing that diarrheal disease, is the second major cause of under 5 deaths around the world. And a major cause of diarrhea disease transmission is the water cycle, and essentially this is the F's diagram of disease transmission. So basically, people are eating their own shit. They're not aware of it, and these are the main routes through which that shit enters our bodies and gives us diarrhea. And the interventions which are in the WASH sector act on certain disease transmission routes. So we have sanitation, which breaks the transmission of diseases in the first round, and sanitation, by which I mean latrines, ensuring open defecation-free areas, and connection to the public sewage system. But then there are these second-round transmission routes, which break the transmission from people's fingers being dirty through, that's hand washing, flies, fields, and fluids in the case of water. This is a slightly different representation of that figure. So that figure is from Sandy Cairncross, who you all know is one of the world's leading experts in this area. Part of the problem with these kind of figures is that they don't really factor in the how it actually works on the ground. And let's say that in the case of a water supply intervention, we provide clean water at source to people. However, people don't drink at source. People carry that water and then they store it in their homes, and then they, typically in a bucket which they'll dip their hands into to pour out of, which basically leads to recontamination of the water. So one of the theories is that if your objective is to improve health as measured by diarrhea and other types of waterborne diseases, providing clean water at source isn't going to solve the problem, because the water becomes recontaminated through the fingers route, as you can see here. So basically, you need to treat water in the household, or provide a clean storage after source water treatment. And just generally, on the extent of the problem, this is from the most recent UN MDGs report from last year. The top figure on the left-hand side in the countries in orange are those countries which are off track. So most of the world, the top figure on the left-hand side is the water supply, global water supply progress. As you can see, Africa's the main area where there's an enormous problem. And secondly, the bottom picture is on sanitation, and again we have Africa, but also India and most of South Asia being off track. And actually, South Asia is the contains the most people in the world which don't have access to adequate sanitation. So, and in fact, 60% of those practicing open defecation, for example, live in India. Okay, so we actually did this review about 4 years ago. We're updating it at the moment now because it's such a productive area of work. There's so many studies coming out all the time. So we're currently conducting the update. The original systematic review report contained some 70 interventions. There's been at least 30 additional studies conducted since then, which we envisage will be included in the review. So we did an extensive search of both published and unpublished sources. And the inclusion criteria for the review, unlike the Farmer Field Schools review, we solely restricted this review to experimental and quasi-experimental studies, which were reporting the effects of specific water sanitation and or hygiene interventions in low or middle income countries on child disease, on child diarrhea morbidity under non-outbreak conditions. So those are the inclusion criteria which we determined before we did the analysis. So just to say that when in a systematic review and a meta-analysis, the unit of analysis is the study level effect size. And what we've done is we turn the summary information, which is reported in the 2x2 table or the regression table, we turn that into a measure which represents both the magnitude of effect, so how much, what percentage or what reduction in terms of numbers of standard deviations in the outcome variable there is due to the intervention as measured against the control group. So in some cases, that information is reported in a 2x2 table. That's more typical in epidemiological literature. In the economics literature, we generally report results in regression tables. So and just as a word of interpretation, what we're going to be measuring today is a negative outcome. So in other words, we're measuring diarrheal disease morbidity. So a reduction in diarrheal disease morbidity in the treatment group as compared to the control group is a positive benefit, which will be in a forest plot like this, shown as a shift to the left of the line of no effect. So this is our kind of overall findings. So if we just did the meta-analysis in which we found 70 studies and we pulled the results for separately by intervention, this is what we found. So each of these diamonds is a separate meta-analysis. So the diamond at the top shows the effects across all of the studies of water supply or water quantity on child diarrhea morbidity. The second one is, and that contains something like 10 studies, so there just isn't enough space on this graph to show it, but there's 10 studies which make up that diamond, that pooled effect size. In the second case, we have water quality interventions. In the third case, sanitation. The fourth, hygiene interventions, hand washing, etc. And finally, combined interventions, so lots of interventions together. And basically, overall, what we find is, if we look across the studies and don't do any further in-depth analysis, that providing improved water supply doesn't lead to any improvements in disease as measured by diarrhea rates. It's actually water quality, so treating the water, which makes a difference. Similarly, sanitation, the width of the diamond shows the confidence interval, so which basically relates to how many studies and how closely together they are, how precisely we're measuring the estimate. So we estimate a somewhat lesser effect on sanitation, but there really aren't very many studies. And I'm not going to talk about the sanitation literature, mainly because it's so weak. There really aren't very many good studies on sanitation. I think there's two RCTs which are in progress at the moment. Hygiene interventions I'm going to talk about today. So I'm going to focus the rest of the presentation on water quality and hygiene, and specifically how you can use meta-analysis to explain the findings from to explain the overall findings. So you going beyond the average treatment effect. So here's a meta-analysis. This shows the individual studies which make up the. Have you got the microphone? I can carry it. So this. Or perhaps I'll shout. Oh, no, we're here. So this larger forest plot shows the individual studies which made up the diamond in the first forest plot I showed. So you can see that there's a large number of studies which assess water quality. So by water quality, I'm talking about an intervention which treats or protects water, and so makes it safe to drink. It makes it potable water. And the first point we did was we separated the studies into interventions which provided improved water quality at the point of use. So, in other words, a household water treatment device like a filtration device or a storage bucket or various other ways of decontaminating water at the household level, and several other studies which provided safe water at the source. And what we found is that we look across the studies that we do see a larger reduction in the household water treatment than the source water treatment, which we expect is due to the recontamination from during the process of transport and storage in the household. So these are the two things to be focusing on here. This is the pooled meta-analysis finding. However, when we're looking in greater depth at the water quality studies, and this is work done by Sandy Cairncross at the London School of Hygiene and Tropical Medicine, when they actually looked at the placebo-controlled studies of water quality, what they found was that despite uptake rates, they didn't find any improvements in the treatment group over the control for water quality interventions. And this is partly because the outcome is being self-reported. So and we know that you have Hawthorne effects, John Henry effects, and there's this suspicion in the literature now that because of Hawthorne effects, that the water quality literature just isn't believable. So there are studies which are ongoing now, which are collecting information on more objective outcomes, harder outcomes. This is some analysis that we did in our study where we compared diarrheal disease outcomes with process outcomes, so measures of whether water was contaminated or not. So they do an assessment of the pathogen loads in the water in the household. And what we found looking across the studies is that we don't find a consistent relationship between the process outcomes and the final outcomes. So this is questioning the scientific validity of this literature, and I should say that this literature is large. There's a significant number of randomized control trials in this literature, so it's a large number but mainly efficacy studies. And so when we move on to looking at sustainability over time, and here's a second meta-analysis where we're grouping the studies according to the length of follow-up period. What we find is a substantial reduction in disease in disease rates in the treatment groups for water quality intervention. So this is represented by this shift of the diamond for water quality to the right-hand side. So studies these are studies which measured outcomes a year or more, and there's additional literature which looks at follow-ups amongst complier groups, amongst treatment groups over time. So after the intervention has ended, there's at least 4 cases from our systematic review which found that compliance rates fell remarkably. So in the case of in the worst case was in Guatemala, which was a water disinfectant trial, And basically, after 1 year later, only 5% of the households were actually using the intervention. So onto hygiene interventions. So again, hygiene interventions, largely efficacy trials, quite a lot of RCTs. So at least in terms of, and if we just looked at the studies in terms of the fact that it was an RCT, we would think, oh yeah, there's a very nice, very good quality of literature. And when we looked, so we've broken down the studies into soap trials and hygiene education, and we didn't find a very big difference. Again, we found similar to water quality, some 30 to 40% reduction in diarrhea in the efficacy studies. And this is from the new findings from the research update. There have been at least 3 new studies which have gone beyond efficacy to scale up hygiene interventions. So, and they've scaled it up through various ways. So in Vietnam, there's been an RCT, which came out last year, which did scaling up through mass media and then interpersonal communication. In Peru, they used mass media and community level promotion through health facilities and schools. And in Bangladesh, they use community hygiene promoters. In all of these cases, they found no effects on health and other outcomes. Now, clearly the message is that at an efficacy level, the intervention appears to work. The point is, how do we then go to scale? So how do we actually, which are the behavioral change communication methods which are working? So at least we have authors which are attempting to use different methods to assess this problem. But at the moment, the results from scaling up using these methods hasn't been promising. Okay, so I'm going to finish there. On time for once, so thank you. You can download the report. There were free copies out there. We are updating the study, which will hopefully be in the Campbell Library in the not too distant future. Thank you.
We have around 10 minutes for Q&A for Hugh's presentation. Take 2 or 3 questions at a time. We'll do a couple of rounds if we can.
Hi, good morning. Thank you, Hugh, for your presentation. I'm Arundhati from PHFI. So from your presentation, I gather that systematic reviews are actually quite powerful in pointing out gaps in both interventions as well as research, if we're looking at a particular health issue. So what do you do with a systematic review? How does this then go back to informing better interventions, better research, and then, of course, funding for those research studies and interventions?
And we'll just take another question as well.
Thank you very much for the presentation. That was very useful. I'm just curious, you know, the results you're throwing up is actually showing where it's been effective, where it's been not effective. Then do you go into round 2 if you want to look at the cost effectiveness, sustainability, you know, the kind of environment that you need? How do you capture that?
Madhumita, can you introduce yourself?
Sorry, I'm Madhumita Gupta. I'm actually the mission economist at USAID. And we're also looking very carefully at how do you do the learning part of the M&E system. So, you know, USAID is actually looking at MEL right now with a focus on learning, and that's what we're trying to capture, and we're trying to set up a framework within the mission. So I'm very interested, how do you actually do that?
Great. Sri, why don't you pass to Hugh to answer these first 2? Yeah, and then we'll do another round in a sec.
Okay, thanks. Yes. Okay, so the question on how do we use SR for research? So you're not interested. I've presented on the policy bit. What you're interested in, to clarify, is how we use it for funding future research. Correct? Research and interventions. Okay. So actually, when and the systematic reviews program was set up by Howard very early on in 3IE's program. I think the first call we ever did was for systematic, that 3IE ever did was for systematic reviews. That was in late 2008. And they were we primarily envisaged that actually we would use the systematic reviews program exactly as you state, to find out where the gaps were in the evidence, and then we would use that to fund future intervention studies. Or they would find the gaps in the evidence, or they would find where, so we could avoid duplication, but also encourage replication where it would be beneficial, where there were promising studies. We actually, when you report a systematic review, you report implications for policy. Many systematic reviews, incidentally, don't report many implications for policy because there isn't very much evidence, and which is why we promote a more integrated synthesis, which Birte is going to be presenting for Farmer Field Schools, so that we can at least provide information for not just what to fund, but also how to improve implementation. And so basically, and when you see the implications section of a systematic review, you'll see both the implications for research and practice, but also, for policy and practice, but also implications for research. So secondly, on the round 2 question, yes, you're absolutely right. The basics of these, I've kind of presented the basics. The first slide I presented was that we just do the simple, collect all the evidence, abstract the statistical information and do the meta-analysis. But the really interesting stuff, and the really stuff which is, we believe, is informative to implementers, is actually the doing the subgroups analysis like I presented, looking at perhaps where the programs are particularly successful, or for which people. And so one method of doing it was the way I presented it, was basically by grouping studies according to particular contextual factors and estimating effects in that way. You can also use, if you have sufficient studies, use more, I hate to use the word multivariate methods, so more like meta-regression to look at lots of different correlation or finding factors together. Sustainability, some of these questions can be answered with subgroups with meta-analysis. Other questions may only be answerable with sufficient studies, or may not be answerable at all without engaging with the qualitative literature. And so for our Farmer Field Schools study, I think it's fair to say that we haven't really been able to strongly make strong recommendations about sustainability due to the limited extent of the quantitative literature, but we can go some way in teasing out a theory using the qualitative literature. And yes, I would see it's the same issue would be around cost effectiveness. There are some reviews which look at cost effectiveness, and we realise that it's cost effectiveness which is of key importance if you're trying to determine which programs to achieve a particular policy objective, but very many systematic reviews don't usually engage with that. It's usually a secondary piece. We're hoping, and we're funding systematic reviews which are looking at those kind of questions.
So, just to add a couple of points. So on the sustainability, I think the presentation does illustrate 2 ways in which you can tackle sustainability. So one, as Hugh mentioned, is subgroup analysis, and that was one of the last slides that showed the effect size, the average treatment effect on diarrhea reduction was much less if you looked at studies that took place measuring outcomes over 12 months after the intervention took place, whereas if you measured it in the first less than 12 months, you found a much larger impact. So the impact's declining over time. So you see that effect of lack of sustainability. Why is it? Again, it was on one of Hugh's slides. There's not only limited adoption of the intervention, there's disadoption. So if you go back a year later, far fewer people are using the intervention. This is particularly true for point-of-use water treatment, because chlorination of your water, filtration, it's a hassle. Yeah? People don't want to do it. They give up. And they don't. We have some discussion about why this might be, and what is recognised in the literature is it's much harder to persuade people to do something where the benefit is something not going to happen. What's not going to happen to your child's not going to get diarrhea. So it's not the same as you're going to get something, something's not going to happen. And the fact is that diarrhea rates are maybe around 12% or so, and it goes down from 12% to 9%. Yeah, children get diarrhea. I don't care. It happens. They'll get better. So as something that a third piece of evidence we have from another review, which is at the back, that confirms this view, is a systematic review we had looked at willingness to pay studies. And the fact is people are not willing to pay for clean water. They're willing to pay for water access, but the willingness to pay for clean water is less than the cost of provision. So, and the same factors explain that. So sustainability and how you can cost effectively provide clean water is actually a real challenge. I myself had a question for Hugh, but I'm going to answer it as well. Hugh talked a lot about effectiveness and efficacy studies. I just wanted to clarify what that is. So when we do drug trials in the health sector, what's called the third level trials are often what we consider efficacy trials. They're seeing whether the drug works under ideal circumstances, if it's administered in the way it's meant to be administered, and often they use what we call ideal patients. So a lot of drug trials are done on 18 to 20-year-old college students, for example. But we don't give drugs to 18 to 20-year-old college students. We give them to people in their 60s at risk from heart attack. And these people are far less likely to recover than our 18 to 20-year-old college students. And when we give it to the 18 to 20-year-old college students, we monitor, did you take this pill when you're meant to take it every day? Whereas in real life, people are out there, they forget to take their pills, they don't want to take their pills or whatever. So the analogy in development is if we go, say, we do a small-scale trial in 1 or 2 villages, and so it's done under ideal settings in that the researchers are part of the implementation team, and they're making sure the fidelity of implementation is good. The program's meant to be implemented properly. That's like an efficacy trial. When you take it to scale, you're trying to reach 100 villages implemented by an NGO without close monitoring of implementation. And so we'd expect the effect to be much less in an effectiveness trial rather than an efficacy trial. And most of the evidence we have, the high-quality RCTs, are efficacy trials. If we scaled up those interventions, then we would expect effectiveness trials to find less impact. And that's a particular issue in other sectors. So, for example, male circumcision, which is recommended across Africa, because there are 3 efficacy trials that show a 50% reduction in onward transmission of HIV/AIDS from unprotected sex if the man is circumcised. They're efficacy trials. We don't know. What we do know is you roll out male circumcision programs. Men don't want to get circumcised. It doesn't happen. But we don't also know what the effectiveness would be once you do trials that are rolled out. And that's a gap that 3i is currently working to fill. So that distinction is really important. And we need to do proper, full impact evaluations of scaled up interventions. We can't think, oh, we've done an efficacy trial, so now we can go to scale and stop there because we know it works. You don't know it works, not once you go to scale.
We'll have to save the rest of the questions for after at the last segment. Before I pass to Sri, this is, and I think when the deworming and the Cochrane deworming study came out last year, there was JPAL South Asia and JPAL has also been promoting school-based deworming as an effective program for education in particular. So what I will just point out is that there is a note that has been put out by the heads of Deworm the World, I believe JPAL and IPA, countering some of the findings in the Cochrane study. And I don't want to get into the details here, because there's a great blog post I saw called the Deworming Brouhaha, which was a lot of back and forth about what studies were included, what the outcome variable that we're mostly focusing on is school increases in school attendance. I don't want to get into the details right now, but I think it just goes to say that it matters which outcomes variables you're looking at. It matters which studies you're looking at. And in general, I think that both Cochrane and 3IE do a very good job of having comprehensive studies.
Our next speaker is Birte Snilstveit, who will present on systematic reviews of farmer field school evaluations. Birte assists in coordinating and developing 3IE systematic review programs in London. She works with Hugh Waddington in coordinating the Reviews Commission by 3IE and the Campbell Collaboration International Development Coordinating Group. Welcome, Birte.
Thank you. Good morning. So we're all interested in identifying policies that help improve people's lives. And I think the discussion this morning has also showed that many of us are interested in the methods that we use to determining the answers to those questions. The systematic review that I'm going to present today is a good example, I believe, of a review that is achieving both of those objectives. So it's making a substantive contribution in terms of telling us something about the effects of farmer field schools, but it's also making methodological contributions in terms of improving the methods that we use in systematic reviews to provide more useful conclusions. So what are farmer field schools? Farmer field schools is a training program for farmers. It's a group-based learning, typically including 25 farmers, and it takes place outdoors in the village, and it's based on principles of adult education and discovery-based learning. So the farmers get to actually practice the techniques that the school is trying to promote in the field and observe the results of the techniques in control plots. And they also practice something called agro-ecosystem analysis, where they the aim is that the farmers learn how they can better use the resources they have available in their environment to combat or deal with some of their problems and improve their farming techniques. So, just a bit of background on farmer field schools. So, farmer field schools originated in Indonesia in the late 1980s, and they were an attempt to deal with a particular problem, which was widespread or reoccurring pests and a problem of pests becoming resistant to pesticides. So the FAO helped develop the farmer field schools, and as a way of disseminating integrated pest management, which is about using beneficial insects in the field, for instance, to scout for those insects and to use those to target the pests, replacing pesticides. After having been implemented in Indonesia, farmer field schools have now spread to all regions of the world, and they're implemented in over 70 countries. And as they have spread, the curriculum that's taught in the farmer field school, or the practices and the techniques, have been adapted to the particular problems of the local context. So, for instance, in Africa, pests might not be the biggest problem of all farmers. Maybe soil fertility is a bigger issue. So the curriculum has been adapted to address those needs. So in the early 2000s, there was a policy debate and a debate in the academic literature about the effectiveness of farmer field schools. So there was this review by Vandenberg, which was looking at a range of studies of the effect of farmer field schools, which concluded that farmer field schools were effective in achieving a range of beneficial developmental impact. Then there was another study conducted by Federer et al., which is considered the first rigorous impact evaluation of farmer field school. And that was conducted by researchers from the World Bank. And that study concluded that the farmer field school did not improve the outcomes of either the farmers that participated in the farmer field schools or their neighbours, because because farmer field school is such an intensive program, and in some cases at least the cost of implementing it is quite high. One of the assumptions for cost effectiveness is that the practices also diffuse to neighbouring farmers. But Federer et al. Concluded that there were no effects of farmer field schools on either. So this was the motivation for our review. So based on this debate, we developed 2 research questions that we wanted to answer. So we'd had some experience of doing reviews in the past where we'd been looking at effects. So we wanted to answer what are the impacts of farmer field schools on outcomes for farmers. So looking at adoption, yields, incomes, empowerment, etc. In addition to that, we also wanted to try and understand if the intervention worked or if it didn't work, why was that? So what are the barriers and facilitators to farmer field schools being effective? So we designed a systematic review which combined what Hugh talked about earlier, and using those methods where you primarily review the quantitative literature to answer the question about intervention effectiveness, with a synthesis of the qualitative literature to address the barriers and facilitators question. So here are the results of our review. So this is just to show you quickly. This is a diagram illustrating the results of our research. So you can see at the top, we screened close to 28,000 records, which seems like a lot, and systematic reviews are often criticised for discarding a lot of useful literature, but actually the majority of those 28,000 records, they were not relevant to either to farmer field schools and in particular not to the questions that we were asking. So actually the number that is the most relevant is the number at the second from the bottom, which suggests that we screened around 700, the full text of around 700 papers, although there are some overlaps to that. And I'd say that is maybe the size of the farmer field school literature that is possibly relevant and its primary research. And then in the end, we included 80 impact evaluations of farmer field schools, excuse me, and 20 qualitative studies in our synthesis. So I mentioned that we did this, we had 2 research questions and we sort of had 2 streams of the review. But a central part of our review, which is bringing those 2 streams together, is using a program theory. So we drew up a quite basic program theory excuse me, for farmer field schools. So one of the first intermediate outcome for farm field schools is that the participants acquire the knowledge and skills excuse me. That are being presented in the farmer field schools. So what our meta-analysis found, this is the results of our meta-analysis, and on the right-hand side, that indicates that the intervention was effective in improving farmers' knowledge. And if it crosses the line or it's over on the left-hand side, it indicates that farm field schools were not effective. So at the top, we present the the results on the effect of farmer field schools on participants. So those are the farmers that actually participated in the training. And we find that overall, whilst there is some heterogeneity between different contexts, overall, the farmer field schools were successful in improving farmers' knowledge. Then, if you see, when we look at the results for the neighbours of farmer field school participants, we find that there are no statistically significant effects on the neighbours. So being exposed to someone who's participated in a farmer field school does not appear to pass on the knowledge to other farmers. Then our qualitative synthesis provides some insights into why we see the results that we see, and also so both in terms of the barriers to effectiveness, but also facilitators. So a key factor at the early stages of the causal change is, of course, the quality of the inputs. So for farmer field schools, the facilitator who is running the field school is a key input. And what the qualitative synthesis suggests excuse me, was that if the facilitators do not receive sufficient training or sufficient quality of the training, in particular if the training did not focus enough on facilitation skills and in participatory techniques, that could be a barrier to them performing their job properly. Typically, many of the facilitators were formerly agricultural extension workers, so they came from a different tradition. So if the training was not of good enough quality, that was a barrier. Also, if the facilitators did not have the appropriate characteristics from the outset, if they were too different from the farmers, if they didn't have experience with farming, that affected the extent to which farmers trusted their messages. And finally, if the facilitators used the national language as opposed to local languages, in some cases that was a barrier because the farmers were unable to understand what they were saying. On the other hand, a facilitator of the facilitators being able to pass on the knowledge to farmers successfully was if they had experience with farming, if they had leadership skills, and also that they were literate. In some contexts in particular, it was important that the gender of the farmer was appropriate. So if the farmer field school was targeting women, then having a female facilitator might be quite important. Although, on the other hand, in some contexts, if the group also included men, then having a female facilitator is not always appropriate. And then, additionally, the qualitative synthesis suggested that a barrier to successful implementation of farmer field school was a lack of timely and sufficient resources to actually set up the farmer field school. So let's move on to the our second intermediate outcome, which is adoption. So studies that measure whether farmers adopt the practices promoted in farmer field schools. So on this slide, because it's about the a reduction of an outcome rather than an increase of an outcome, it's the opposite. So if the point estimate is on the left-hand side of the line, it indicates that the intervention was effective in achieving its outcome. If it's on the right-hand side of the line, it suggests that it was not effective in reducing pesticide demand among participants. So for the farmer field school participants, so again those that participated directly in the farmer field school, the meta-analysis suggests that the farmer field schools were effective in actually getting in reducing farmers' demand for pesticides. Thank you. But then when we look at the results on their neighbours, again, there is no statistically significant effect on farmers being exposed to other trained farmers, reducing their use of pesticides. So for the in the qualitative synthesis, four key themes emerge as explanations for the results. So firstly, the approach to learning adopted in the farmer field school appears to be important to determine effectiveness. So I mentioned earlier that the participatory approach and discovery-based learning is an important part of the design of the farmer field school. What the synthesis of the qualitative evidence suggests is that in some cases farmer field schools were implemented more in a top-down way, as the traditional extension would be delivered. And in those cases, whereas we can't actually trace that directly back to an effect size, it suggests that if farmer field schools were not sufficiently participatory, that was a barrier to effectiveness. On the other hand, when the approach to learning was more participatory and the farmers were allowed to observe, to practice the skills in the field, that was a facilitator of farmers adopting the improved practices. Secondly, relevance of the curriculum appears to be an important factor in determining effectiveness. So I mentioned earlier that farmer field schools started in Indonesia and they've now spread to a range of different countries. So in some cases it appears that the curriculum of the farmer field school was not then sufficiently adapted to the local context. So it was not always relevant what farmers were taught in farmer field school. They might gain the knowledge, but if they didn't feel that it was relevant to their problems, that might be a barrier to actually adopting the practices in the field. But on the other hand, if the curriculum was adapted to the local context and farmers felt that what they learned in the farmer field school was relevant to them, then that appears to be a facilitator of adoption. And thirdly, observability seems to be an important explanatory factor. So part of the farmer field school is to the use of control plots where farmers get to compare their traditional practices with the improved practices. So if in some cases those control plots actually failed to produce a convincing result, so in those cases that was a barrier to adoption. On the other hand, if farmers were able to observe the benefits of the new practices, either in the control plots or in their field, that was convincing that the practice had a relative advantage and was worth adopting. And then finally, the policy context matters for adoption. So in some countries, there might be a policy of providing agricultural subsidies to of pesticides or fertilizers, and if the farmer field school was then trying to encourage farmers to reduce their use of pesticides or replace fertilizers with other more natural techniques, then that might be a challenge for farmers to adopt the new practices in those contexts. And also in many countries, the pesticide industry appeared to be quite powerful still, and the old links between the pesticide industry and the agricultural extension system could also act as a barrier to adoption. And finally, looking at the effect of farmer field school on final outcomes for farmers, and I'm only going to focus on a couple here. You can see the rest in our report. So we're now back to, so it's about yield increases. So on the right hand side suggests a beneficial impact, and indeed for the farmers that participated in farmer field schools, there was an increase in yields. Whereas for the exposed farmers or the neighbours of the participants, there were no statistically significant impact. And then looking at the revenues for farmers, so one of the benefits suggested of integrated pest management, for instance, is that it reduces the cost of inputs for farmers. So we find that for farmer field school participants, there was a beneficial impact on revenues. And there were also a group of farmer field school which had an additional component of input or marketing support. And there again, we observe a beneficial effect on revenues. In this case, we also actually observe a beneficial effect on the neighbours of participating farmers, which is inconsistent with the rest of the meta-analysis results. So our explanation for this, and Hugh might elaborate on this later, is that so these results are from only 2 studies. Well, actually, there are 3 on here. But so we suggest that maybe these results are not that reliable. There are some issues with the number of studies and also the quality of the studies. So the story that's kind of running through our meta-analysis and synthesis along the causal chain is that whilst there is an effect on the farmers who participate in farmer field schools, there are no effects on those that don't. So there is a breakdown in the causal chain, so no diffusion effect happens. So why do we see no diffusion? Well, the practices promoted in farmer field schools are relatively complex. So it's not just about knowledge and transmission of information, it's about practicing and learning new skills. And I'm sure that we've all got experience of trying to learn a new skill, and it's not always possible to do that by having people tell us how to do it. We did a qualitative synthesis by, we learned to do it by doing it. We read a lot about it beforehand, but we didn't really understand what it involved before we did it. So that also appeared to apply to farmer field schools. And another factor which farmers reported was that, so the exposed farmers, they were generally unable to observe the benefits, and some of the benefits with the practices promoted in farmer field schools are not immediately obvious in farmers' fields. So that was one issue. And therefore, they were not convinced of the relative advantage of adopting the new practices. And finally, socioeconomic differences between the participants in the farmer field schools and their neighbours appear to have been a barrier to adoption. And in some cases, so the social networks of the participating farmers did not extend much beyond the group of 25 farmers who participated in the farmer field school. And I think these 3 factors are consistent with Roger's theory of diffusion. So it's a characteristic of the farmer field school intervention which suggests that it might be difficult for it to diffuse spontaneously. So to conclude, the evidence suggests that farmer field schools are effective in improving the practices and agricultural outcomes of farmer field school participants. It seems that it's important that the farmer field schools are implemented in a participatory, experience-based manner, and that the curriculum is adapted to the local context. But the practices do not diffuse to exposed farmers and neighbouring farmers, and as I just said, that this appeared to be related to the characteristics of the farmer field school intervention primarily. So it seems like to achieve diffusion outcomes of farmer field schools, and also, so I haven't reported anything about sustainability, but to achieve diffusion and sustainability, it seems like an additional additional support and backstopping might be necessary. And finally, I think that systematic reviews using a program theory and combining different types of evidence can produce more useful conclusions, and I think that our review has showed that. Thank you.
Let's again take a round of
Hello, good morning. I am Manoj Raut from Microinternet Initiative. Usually used to do literature reviews during our publications, writing publications. But in systematic reviews like what we have seen here, and we used to be doing in vitamin A, like coverage evaluations, and we see like a lot of studies have efficacies. A lot of studies don't we don't see efficacies. But when you do a systematic review, we see that how many studies we are going to take, like to see that whether the positive outcomes, we are going to take the positive outcomes or the negative outcomes, whether there is a rule of thumb rule or something, or whether we think like we can get close to any kind of number of studies which we get access to through electronic or any means. Thank you.
I'm more interested. Hi, I'm Preeta Menon from Public Health Foundation of India, and I'm more interested in how you went about doing a qualitative synthesis, the process. Did you limit it to just the studies that you took up for the quantitative meta-analysis? Was it a subset of that? Or did you take up other studies which had just the qualitative aspect and not the quantitative part? And even among the findings that you're getting from different review that you did you filter it? Like, did you take out those studies that didn't have a good impact or a substantial effect size? Did you filter it across those studies, or did you take it all in one go? And how do you know that the findings, if there is a situation where you have conflicting findings, like one study says this is good, the other one says this is not, so how do you take a call on that? And the fourth doubt again that comes here is, how do you look into the quality of the qualitative studies that you do? Like, which ones do you take, or which do you think haven't been done with the rigor that should be in a qualitative study?
And I'm going to add to her question if I can. One question I have just related is for each step on the causal chain. So you basically had knowledge transfer, adoption, and yield, and final outcomes. Do you find across the studies that you're doing that there must be those consistent results that are available and comparable, or those kind of universal indicators that are comparable across studies? And then the second one, because I know that's a challenge for JPAL when we do cost effectiveness analysis, is sometimes those studies don't have the same outcome variables. And then the second question related is basically, can you say a little bit about how you weight the studies? So, because in the meta-analysis, it seems to me that you're putting together, you're looking at the total observations for a particular study, and then you're putting that together with other observations from other studies. So if my study had 6,000 observations and Howard's only had 200, then it seems like my study would my study would kind of dominate the results. And so I know that you do some kind of weighting, but I just would like to hear a little more about that. And just one more back here.
Hi, Preeta's actually already asked the question I was going to ask about qualitative research more generally and their use in systematic reviews, because so many of the studies are ethnographies and so context specific. So just wondering about the challenges of using studies like them in a more, how do you compare one with the other? the purpose of qualitative research is so different from the studies that we use. Yeah, I'm Nupur Barwa from DFID's South Asia Research Hub.
Yeah, my question is a related one. I mean, how do you, kind of decide what kind of the research studies you are going to do for, systematic review, and what are the, how is it different from the meta-analysis we do? I mean, what are the advantages of doing that systematic review, which you have covered already, but I just want some specific answers for that. And she has also pointed about the qualitative thing. What are the methodologies used? Thanks.
Can you introduce yourself?
Yeah, I'm Chandan from USA.
Okay. So the first question, how many studies should we include? So the aim of systematic review is to identify all studies that meet your inclusion criteria. So if you're looking at the effect, so we were looking at the effect of farmer field schools on farmers' outcomes, then we want to try and identify all studies that address that question. And that involves looking at both the published and the unpublished literature, writing emails to experts, etc. And one of the reasons for doing that is to avoid publication bias, so that we also, so commonly the reviews, the studies that find negative or non-significant results are less likely to be published. And you also asked whether there is a point where there is an upper limit of number of studies. So again, we want to include all of the available studies, although I do think that there might be a point where if there are a sufficient number of high quality studies, we can say that we're quite confident in the answer to this question, so we don't need to fund more impact evaluations. Yeah. And then in terms of the questions, so I'm going to deal primarily with the questions on the qualitative synthesis on the Farm Field Schools review, and then Hugh, who's led the work on the quant, will address the questions relating to the meta-analysis. So I will start with the inclusion criteria and the process of how we did that. So as with the quant, we set out at the beginning the types of studies that we wanted to include, and we adopted a minimum criteria for the qualitative studies for them to be included in the first round, so that they had to report some information about objectives, some information about sampling, and some information about the sample. Not a lot of detail, but just a bit of information. And so then we sifted through a lot of studies and identified those that were of sufficient minimum quality. And then we used so there are around 100 different checklists and tools for assessing the quality of qualitative studies. So we combined a couple of those into a checklist that we applied to all the studies. So we were 2 people assessing the quality independently, and then resolved any issues with the advice from a third person. And then we extracted data from the findings of the studies, so detailed line by line coding, and first we extracted quite a lot of information, and it was a process of reading it and rereading it and actually drawing out the common themes. And we started with a coding framework which was based on our program theory, and what I didn't show on the slide because it looks very messy is that we have also a range of assumptions underlying each step of the causal chain. So those were things that influenced our coding. Also, Roger's theory of diffusion was informative in the coding framework. And then there was several stages of iterations of trying to synthesize the concepts and drawing out, obviously keeping the context of whether a particular factor was what was a barrier and what was a facilitator. So what we've produced now at the end is, so there's a write-up of this, and we have updated the program theory with additional assumptions that we think that, based on the quality of evidence, need to hold for the farmer field schools interventions to be effective. And we also have a separate model where we kind of graphically illustrate the barriers and facilitators. And then there was a question about ethnographies and how you combine those studies. I think that it is a tension in qualitative synthesis, whether you should take context-specific findings and combine them. I think, having done it, I think that they can still, and I think the way that we present them is that these are suggestive factors, and they do not necessarily apply in all contexts, but I think that they are still useful in informing implementation and practice in other contexts that can be useful lessons. I think that there was gentleman at the back. Have I addressed your?
How do you select those research studies to do a systematic review? What is the kind of the qualifying things? Like there will be 2,000, 3,000 studies. How do you segregate and decide which are ones you want to do a detailed one?
So based on your research question, you define your inclusion criteria in relation to the population, the intervention, the comparisons and the outcomes that the studies need to look at for you to include them. For the qualitative synthesis, we don't look at obviously at the comparisons and outcomes, but we look at factors related to the barriers and facilitators of farmer field schools. So those are the criteria that we have, and then we apply them first at the title stage, at the abstract stage, and then we read the full text of all the papers and base that kind of filter through our screening and decide which papers are relevant for our research questions.
Okay.
Yeah.
Thanks.
So just to elaborate on this point about the qualitative synthesis mainly, systematic reviews traditionally, particularly those done by the Cochrane collaboration, which is public health, but also the Campbell collaboration, of which we're part, which looks at social interventions, have focused on quantitative synthesis, using sometimes meta-analysis, sometimes not. And we did mention, and I believe it to be true, that 3I is bringing substantial innovation in techniques to the field of SRs, systematic reviews. And this is primarily, not only, it's also on the quantitative side, but primarily on the qualitative side. And the way in which we're doing that is to ensure the same principles of systematic review techniques are applied in the qualitative field. There's nothing inherent about systematic reviews that makes it quantitative. What systematic review requires to be is systematic. And so, as Birte said, you want to capture all relevant literature. So you do a very comprehensive search, which shows, as the table showed, you find 20,000 studies. It's not unusual. You start 20,000 studies, and you come down to 10 or 12 included studies. You actually have been through 20,000 studies to get down to those 10 or 12. As Birte mentioned in her presentation, people often get upset if you're throwing away 19,994 studies. But it's not actually that big number that matters. A lot of those won't be relevant. They'll be publicity material from NGOs and so on, stuff you find in your searches that clearly are not studies of the impact or any other part of the causal chain. So you come down to 200, 300. And as Birte was saying in her presentation, it's the step down from those 200 and 300 down to the 10 or 12 included studies where you're making the critical decisions. And you might be looking at effectiveness. the impact of the intervention on the outcomes, which is typically, they're not always quantitative, but you might be looking at other steps of the causal chain, like the barriers and facilitators to adoption. And the key question in your inclusion criteria is this credible evidence? And what you need is some inclusion criteria allows you to decide if this evidence is credible or not. This is not something some bloke I met at the pub told me. Yeah? This is something I can demonstrate I've got some scientific methodology. And so, as Birte was saying, people need to be explicit about their methodology. And a lot of our inclusion criteria are about being able to judge whether it's credible evidence because their methodology for collecting those data are clear. Now, we know in ethnography you don't do random sampling, and we're fine with that. Ethnographic studies do get included in the qualitative synthesis. And so it's about knowing that it's clear what the methodology was, so you can include that study, and then we're systematic in the synthesis of the data from the qualitative studies. Because all the while, we're trying to avoid cherry picking. It's one of the problems with literature reviews, because you haven't got systematic inclusion criteria. People can ignore studies that don't fit in with their argument and only include those that do. Systematic review won't allow you to do that. And the way I like to do this, but we have some differences of opinion here, is what I call an evidence matrix. And the evidence matrix, you have each row is an intervention, each column is some issue you're looking at, and you fill in the cells. From every study you've got, you fill in the cell on the evidence matrix from the data you have in the study, and you can then do what we call a vertical synthesis down the column, all the data you have on that particular issue from the qualitative studies, and a horizontal synthesis that allows you to read across the causal chain of the data in that particular study. So these are systematic ways of collecting and analysing this data, and that's what's key to a systematic review.
Thank you. I don't have anything more to say. Okay, so just on the questions about the meta-analysis, well, actually, there were questions on the pooling of findings. What do you do about studies showing big effects and studies showing small effects, or high quality versus low quality, or positive and negative effects? Basically, this is why we do meta-analysis, because what it enables us to do by weighting the studies according to the inverse of the variance, which is essentially closely related to the sample size. So studies with big samples get weighted more heavily than studies with small samples. By looking across all of these studies, we say something about what the average treatment effect is looking across all the studies under the assumption that, to use statistical parlance, it probably isn't statistical parlance, but under the assumption that all of our studies, they're not necessarily from the same sample population, but the only differences which explain across findings, in addition to chance, are contextual factors. So the methods that we use are statistically valid in enabling us to do that. Now, what we don't believe is that actually just looking across all of the studies is the whole or even the main answer, and we do believe that looking at heterogeneity and impacts according to contextual factors, according to good versus which includes things like low versus high quality studies, looking at whether we have outliers and what the reasons are for those outliers in terms of particularly large or particularly negative effects. There was a slide that Birte had on this, which she had to cut out at the last minute, I think. A really good study, and unfortunately it's a bit dependent on how many, obviously as you cut the evidence down to fewer and fewer studies, you have fewer studies in each subgroup analysis, so it's a bit dependent on the total number of studies. But you can say something about answer all of these questions, and this is what we try to do in the report as much as we possibly can based on the number of studies. Yes, there were lots of outcome measures, so there isn't really a there aren't exactly standard outcome reporting. So studies on yield, studies on adoption rates. Some would measure adoption in terms of number of pesticide sprayings. Others would measure it in terms of the volume of liquid sprayed. Others in terms of the cost of the spray. So we did collect and code that, and what Birte presented was the overall synthesis. But when we actually look at, when we disaggregate by the different types of outcomes, we don't actually see any differences, and that's why we present the overall findings still. Also, the way that we calculate, we've used response ratios, which are a bit like the risk ratios in terms of measuring the effect size. So you measure the change in the treatment group divided by the change in the control group, and that actually measures everything in analogous to a percentage change, which also enables, which is a unit, which enables you to account for contextual units of analysis. Yes, that was, what? And apparently we have to go and get on a plane, so I'm going to stop. Thank you.
Yeah, I'll do the 30. Well, first, so now we have about 10, 15 minutes for coffee outside. And Birte and Hugh, I just want to thank you very much for joining us today, especially squeezing us in before your flight. Let's give them a round of applause before we go to their flight. Great, so let's have coffee outside. We'll have to bring, probably inevitably some people have to bring it back in, so we can aim to start in about 10 or 15 minutes from now.
Welcome back. Before we start, a quick reminder, if everyone could please fill their feedback forms. Our next speaker is Howard White, and he will present on systematic reviews of education evaluations. Howard White is the Executive Director of 3IE, Co-Chair of the Campbell International Development Coordinating Group, and Adjunct Professor at the Alfred Deakin Research Institute at Geelong University. Welcome, Howard.
Okay, so I'm talking on this topic of education, and I'm presenting the results here from a review whose title was The Impact of Interventions to Increase Enrollments in Low Middle Income Countries. So it's a very broad review looking at a very broad range of interventions, which is the issue I'm going to be talking about as my methodological issue, is the one of lumping versus splitting, which sounds a bit odd right now, but you'll soon get to see what the point is. So the forest plot I've got here is a forest plot across all the included studies that have data on enrolments. And as we see quite clearly, the vast majority of studies do find a positive impact on enrolments, and so the little diamond at the bottom shows that interventions to increase enrolments have a positive impact of increasing enrolments by somewhere around 20% or so. So the question is that in any sense a meaningful statement? Should we be saying that or reporting it? Now, we had quite a lot of discussion of that issue. Discussion's a polite word, I think, what happened in our office about whether to report this overall finding or not. Now, why did we have these quite heated discussions on that topic? When you do, think back to clinical trials. Meta-analysis really developed under the Cochrane collaboration with pooling data from clinical trials. And the assumption you're making in doing a meta-analysis is that every single study you get is simply taking another sample from the same underlying population. So the characteristics of the treated population, they're the same, taking a sample from the same population. And they're being given the same treatment, the same particular drug, in the same setting, in the same context, same intervention, same context, same treatment. That's clearly not true here. It's clearly, we know these interventions actually vary. They're not all the same intervention. Some are in Africa, some are in South Asia, some are in Latin America. The context varies, the quality of implementation varies, and the underlying populations, of course, vary. So is it legitimate to do this or not? Now, I think to answer that question, you do want to remember why we do meta-analysis. And Hugh spoke about this when he was talking about the Cochrane collaboration logo. We can simplify that even further to say, let's just look at two studies. Here is our line of no effect. And we have one study, sorry, you can't see this, but you have one study like this. So it's quite a large confidence interval. It crosses the line of no effect. So this study finds this intervention doesn't work. And you have another study that looks something like this. quite a large confidence interval, not so large, it doesn't cross below no effect. Now, when you see this visually, like this, you actually can see the average treatment effect from the two interventions is around the same. The point estimate of the impact of this program is about the same. Now, if you were to use what we call a goal scoring approach, which is simply to add up how many studies find an impact and how many studies find a no impact, which is what most literature reviews do, you would say the evidence regarding this intervention is mixed. There are two studies and they contradict each other. What sensible interpretation of this diagram is that these two studies contradict each other. These studies are clearly enormously consistent, except that this one has lesser power probably because of the large confidence interval, probably driven by lower sample size. It might be more variance in the outcome, but probably it's a smaller sample size, leading to the larger confidence interval. So the sensible way to combine these data is to do the meta-analysis, which is the inverse variance weighted average of the effect size estimates, to see what is the overall effect of its intervention, and you get the little diamond here. That's the only sensible way to pull these estimates. To do any sort of goal counting and say these studies give inconsistent contradictory findings does not make any sense. So there's really a very strong argument for doing meta-analysis. But of course, we've got this assumption. So my view on should we report this or not, and you will find this diagram and this summary in our report. We've written on this. Now, it might just be because I'm the executive director, so I have to do what I say, but I like to think because I won the argument intellectually. So let's suppose I won the argument intellectually. And the reason for doing this is that this is actually a very important piece of information. There's a lot of development pessimism, a lot of views that any government programs or donor-funded programs around the world don't work. What we have to say here is, actually, if you pull together all the evidence we've got on the effectiveness of government programs to increase enrollments, on average, they do work. What we're doing is making a difference to enrollments. And I think that's an important headline finding from this review. And they don't only work on enrollments. Just dismantle this, not meant to do that. They also work on attendance. So not only children being enrolled to go to school, but actually attending school. The interventions also work. Even when you turn to learning outcomes, there's less evidence, but overall, interventions we have in education do improve learning outcomes. Now, the evidence here, the impact estimates, the effect size estimates, are quite heterogeneous. So we're a bit reluctant maybe to pull them. But the point is that overall, on average, these interventions work. Now, what the argument we had in our office was about, well, how do you interpret this on grounds? Because the fact that we're saying, on average, there's a positive effect on enrollments and attendance and learning outcomes is not the same as saying everything works. It's not the same as saying, well, anything you're doing, therefore, in education is a good thing. Because we're not finding that. We're finding, indeed, there's heterogeneity here. We haven't analysed it. It might be chance heterogeneity, but it might be related to the type of intervention. And, of course, there's an enormous number of interventions in this sector. So what we did for this study was to develop a typology of education interventions. The most obvious distinction is between supply and demand. Break down supply and demand, you break those down under a number of categories. So this is the same as Hugh did in the water supply and sanitation study. So we looked at the overall impact of WSS programs, but we said, well, there's water quantity, there's water quality, there's hygiene, there's one on sanitation. So we looked at those four separately. I mean, even when we came to hygiene, there's a difference between hygiene education and providing things like soap. So as you dig down, you can always find more distinctions you want to make. And Whether you want to summarise it at the level hygiene interventions work, or you want to say, no, I actually want to know the difference between hygiene education and SOAP, depends on what your question is you want to answer. So the fact is, if we had cost data, and we sadly don't have cost data very often, so we can't do proper cost effectiveness, but the fact is, sanitation, building latrines and so on, is much more expensive than hygiene. And so if we can show that hygiene in general, be it education or SOAP, is as effective, which it is, as sanitation, and we know which is cheaper, then that's sufficient to say, well, let's focus on that area of interventions. So similarly, here, on the supply side, we might build buildings, build new schools, or renovate schools, train teachers, or have more teachers, which might be volunteer teachers, untrained teachers. A lot of heterogeneity in this category. This might be books, it might be ICT, it might be computer-assisted learning. Again, a lot of heterogeneity, even in these categories. Of course, this is the lumping versus splitting debate. So lumping means you put everything together. You just review all of your studies as if they're the same intervention. Splitting means you analyse each intervention subcategory by itself. And which is the right answer and which is the wrong answer there? Well, in favour of lumping, comparing interventions is more policy relevant. So I'm not saying that you should lump all the interventions and make one average treatment effect for all education interventions. But as policymaker, I would like to know whether building schools or training more teachers is more cost-effective in improving learning outcomes. That's what I want to know. If you tell me, oh, building schools works, well, I'll say, that's fine, but I've only got so much money. So how should I spend that money? Should I spend it on building schools or training teachers or getting computers into schools? Which of those works best? And so a review that lumps, carries everything together, has the potential, because it has the evidence inside it, to compare those different categories of intervention. So lumping gives you an opportunity to make a more policy-relevant statement. And when it comes to actually doing a meta-analysis or systematic review in general, there are few studies in international development anyway. So if you were to restrict it to, say, buildings, building classrooms, there are very, very few rigorous studies of the impact of development programs, of school building programs on the outcomes of interest. Well, why then wouldn't we lump? Why would we split? The simple fact is that, well, the first reason I mentioned, that you may not want to combine stuff that's heterogeneous. This stuff is not the same, so you shouldn't combine it into a single point estimate. My answer to that is it depends on your question. Sometimes you should do that, but sometimes you shouldn't. But the main point to me would be that this causal chain analysis of the sort Birte presented, it takes a long time. It's quite difficult. Not many people really get how to do it yet. And so if you want to do that and do it properly for every different subcategory of intervention you've got, back on our diagram of our 20-odd subcategories of intervention, if you're going to do it for each of those individually, because they all have different causal chains, then that is really a very, very time-consuming exercise. And so if you're going to do a lumped systematic review, and the education is a lumped systematic review, there's a limited amount of information you're going to be able to get on the causal chain. So there was a very good question asked over here about where did you get the evidence for qualitative synthesis from? And the easiest way to do that is to simply take the qualitative information in the included studies. By the included studies, I mean you do a quantitative meta-analysis, and you include those that have rigorous experimental or quasi-experimental designs, and then you go through those studies, and you find the qualitative data in those studies. But when someone does a rigorous randomized controlled trial, they don't care about qualitative information very much. And so there isn't much qualitative information in those studies. So the alternative is to do a whole new search with all new inclusion criteria for the qualitative synthesis. That's out of the question. That's just going to be very time-consuming. You can do it, but it's going to be very, very time-consuming. What we did in this case, I don't think Birte made this clear, what we did, not this case, what we did in farmer field schools was to say, we'll restrict this search. Oh no, actually we did do that. Initially we restricted the search to those qualitative studies undertaken in the countries where we had an intervention in the quantitative synthesis. So we thought, okay, we're going to have some exclusion rule, so we've got evidence from the same countries, we can try and combine the evidence. And we got that way 100 included studies that we screened. So I thought, well, that's still quite few, so let's actually include all countries. And then it went to 200 that we screened for the final cut. So there's different ways of doing it. But you're going to try and do a big lump study. You're not going to be able to do that separate qualitative search. Because in qualitative search, you're looking at project documents, which come from a whole different source. You're looking at, as we mentioned earlier, ethnographic literature, sociology, process evaluations. It's a huge literature that really you're going to have to do a full text search on. So what we've done in this case is to draw what we can primarily from the included studies. Where there wasn't much information at all, we went back and got some general information on the intervention. So we could describe the intervention better from some general documents. But we didn't do a qualitative synthesis in the case of this education review. Yeah.
If it was lumping and splitting in this case, can you give just an example of the types of questions they would be answering? So for which groups, in the case of education?
Coming up. So the compromise is really to do lumping of subgroup analysis. And the main subgroups you take will be the intervention categories. So you're going to ask the does it work question by subgroup. This is primarily an effectiveness review, which means we're primarily looking at evidence of causal effects from intervention to outcomes. There's something I meant to say earlier when I was doing this diagram that I forgot that relates to John's question before the break, when he asked about did they have the same class of outcome? So you could pull them. Now, again, going back to the medical literature, most studies in clinical trials report their results as odd ratios or risk ratios, and you can get from one to the other very easily. That's not true in the literature that looks at development interventions. They often use regression-based estimates if they're using quasi-experimental designs, and even for RCTs, they often run OLS, ordinary squares, with the assignment variable as an instrument in that regression for being in the intervention. And so you have to be able to take the regression coefficient and make it comparable with the other coefficients you've got. And so what we do is what we call extracting the effect size. We convert all the estimates from different methodologies to an odds ratio, which is actually a frontier area of research that we've been doing in the 3IE and working with Cochran and Campbell to get them to incorporate a broader range of methods by explaining how you can extract effect sizes from different types of studies. But they may not be truly comparable for two reasons. Now, the obvious one is the first SR I ever read was a water supply and sanitation done for the World Bank, and there they had outcome variable. The main one is child diarrhea, that's what we report, but they also had outcomes on cholera and on mortality from some studies. And they converted those to outcome ratios and combined them all into one single meta-analysis. To me, that doesn't make sense. These are different outcomes. But you can do it. So the answer to John's outcome is, the question is, it doesn't matter if they're measuring different outcomes, because once you convert it to an odds ratio, you can combine anything. It may not make sense, but you can do it. So they combine the different outcomes because you convert them to a single, what I'm looking for. I forgot what the word I'm looking for, so forget that. Move on. The second reason why you may not be able to combine them is these effect size estimates may not be measuring the same thing with respect to what their treatment effect is. So if you do a regression discontinuity design in your primary study, you're comparing the impact at the margin between those just in the intervention and those not in the intervention. If you do a randomized controlled trial, you're typically comparing the average treatment effect on the average impact on those in the treatment group compared to the comparison group. These are different estimates. They're measuring different things. And so you shouldn't just be pooling them into a single effect size estimate. And how you can adjust those, and so you can pool them, is beyond the frontiers currently. So that's where we're trying to get to at the moment. So anyway, back to the plot. Lumping subgroup analysis, the main subgroup would be the subcategories of the intervention, but you might also do it by region, and of course you can do it by region by intervention. You could do it, for example, between boys and girls. And now I'll tell a sort of story out of school. So what we're presenting here is our version of a review that we commissioned. And the review we commissioned had, I think, some fairly serious flaws in it. And so one flaw was that it focused on enrolments, and that was the primary focus. So when they had studies that reported the effect on learning outcomes, we told them we want to include learning outcomes. And they said, okay, we agree. But if they had studies that reported only the impact on learning outcomes, they didn't include them because they had no estimates on impact on enrolments. So they threw away 9 perfectly good studies that had outcome data on learning outcomes. But okay, fine. The other thing they did, which was more egregious, I think, was that when a study had different point estimates, so for example for boys and girls separately, or rich and poor separately, or poor and not so poor separately, they averaged those and gave a single point estimate for the study. Now partly that's just wrong, you shouldn't average them, you have to do a proper statistically combined element estimate. But the main point there is nearly all studies in education do report the impact on boys and girls separately. So what would have been really interesting would be to capture the data on boys and girls separately and do a separate meta-analysis for boys and girls of those studies. They didn't do that, they averaged them across boys and girls. They did report an analysis of what's the impact of education interventions on girls versus boys, based on comparing the few interventions they had that were exclusively focused on girls only, like the Bangladesh secondary school stipend program. So if I had a program that only looked at girls, then it was included in looking at the gender analysis. But that was the wrong way to do it. We had data in the primary studies that would allow you to look at differential impact by gender, and they threw away that data by combining the estimates. We're updating this study, and we're not allowing them to do that, we're doing it ourselves, so we can correct these errors we thought took place in the original study. So we would want to do, for example, a gender analysis as part of our subgroup analysis. So I'm going to pick out a couple of, well, actually I think only one, of the examples from the different type of education interventions that we had. Well-known one is conditional cash transfers. What is most well-known is Progressor, though of course actually the program in Bangladesh started earlier than this. And so Progressor is a conditional cash transfer which pays a lump sum to households provided the children from the household stay in school, have a certain attendance record and achieve a certain grade. I think those requirements are there. In Brazil, the Bolsa Familia program, largest cash transfer in the world, is reaching 12 million families by 2010. So we're putting this sort of historical information and scale of program information into the study. So this is sort of the background information that we're extracting from the reports we've got or we're looking for elsewhere to make the report come alive a bit. If you've ever read a Campbell or Cochrane review, you'll know they're not terribly readable. And they're certainly not accessible to policymakers. So part of our goal at 3IE is to do what we call the front end and put it in a readable format with the more technical stuff going to the annexes. And part of that is just giving some feel for the interventions by providing this sort of information about dates and sizes of programs and so on. And then we describe the program. So education typically is 80%. You have to be at school 80% of the time. And you have to attain a certain grade for the household to receive the cash transfer. The conditions might also relate to health. Usually that's that the mother attends antenatal care and the child is immunised according to national immunisation recommendations. And they're often targeted, both geographically. So in Progressor, when it started, it was a rural program. They picked the poorest areas to go to first. And then often means test within the community, so only poorer households are eligible to receive the transfer. Not always the case, but it's usually the case. And we can try and tease out some design questions, what I call second generation impact questions. So the first generation question is just does the program work, but second generation questions for conditional cash transfers will be do conditions matter? Do you have to actually give conditions to get the program to put children into school or not? The little evidence we have suggests that is the case. There is an impact with no conditions, but it's bigger with conditions. The timing, nature, and size of the payment. Does it matter how much you pay? So interestingly, in Bangladesh, female enrollments continue to rise, even though the size of a stipend was far too small to possibly cover school fees and other school costs. The timing, there's evidence that if you give the transfer in a lump sum just before school fees are due, it has a larger impact on enrolments, but if you give it equal payments throughout the year. Can you give it in kind, or do you have to give it in cash? So we're doing a study actually with JPOW in Bangladesh, looking at giving cooking oil rather than cash as a transfer. And who to give it to. There's a large literature on intra-household allocation that suggests women are more likely to spend on household welfare goods like education and health, and men are more likely to spend on what we call adult goods, alcohol and tobacco and so on. So does giving it to the mother make a difference rather than giving it to the father or directly to the child if they're a bit older? So we can probe the studies to try and answer some of these questions as well. We don't just answer the does it work question. But turning to does it work, here's conditional cash transfers looking at the impact on enrolments, and we do see, you're now familiar with the forest plot, that the overall impact on enrolments is positive, as I said, around the order of 20% impact on enrolments. Here's breaking it down by region instead. Most of the studies on conditional cash transfers find a positive impact. Studies looking at school fees, but there are only a couple of them, so paying school fees for children find no impact, and school-based management, only one study, finds a positive impact. So once you disaggregate by region and by intervention, you get down to a very small number of studies. So it's not really a meaningful synthesis. And that came up earlier. One of the main things we find from doing SRs and development is we need more studies. Even in clinical medicine, where there are thousands of trials, they still say, oh, we need more studies to really know the impact of this drug. We need to have tried out in real-life populations, more trials to find out. And so clearly, here we need more studies. And here I have also data on Africa. Evidence base is much more limited. Fewer things work, but CCTs work. New schools plus SBMs in one program that combines both of those. Early child development works, but school feeding, providing information, school fees, none of those work. So the question is, this is meant to be a systematic review. We're meant to try and synthesize this information. So how can we synthesize the information? So here's one way of doing it. We're looking again at enrolments and attendance. And we're looking at the average effect size. So this is how far is the center of the diamond to the right of the vertical line. And the number at the end of the bar is the number of studies. If it's in yellow, that means the finding is significant, that the diamond lies entirely to the right of the circle. There's a positive impact of the intervention on enrolments or attendance, one of those two. So here's one way of trying to summarize this data. It allows you to pick out what seems to work. As has been stressed already, this isn't really the diagram we want. The diagram we want has cost effectiveness along here. So as some of the synthesis that JPOW has done, it says, for example, the cost per day, the cost of getting a child in school for an extra day. And that would be the useful thing to have on the x-axis. We can't have that because too few primary studies, and too few means less than 10%, have proper cost data. And it's quite ironic because in the health field, people bring economists into their team because they think economists do cost effectiveness. Actually, economists don't do cost effectiveness at all when they come to doing their own studies. And they really should be. And we're sort of making it a requirement now through AI-funded primary studies that you do cost effectiveness. We've had a lot of kickback from our researchers. Well, we shouldn't really be doing that. We can't do it. But we are pushing very hard to try and have cost effectiveness analysis included so we can do meaningful systematic reviews that do compare interventions based on a cost effectiveness comparison. So trying to pull together all the data we've got, we made up a matrix like this. And so we've got what works, what doesn't work, what's promising, not promising, but a lot further research, and we don't know. And so, let's try and get this right. What works and what doesn't work is it finding a positive impact or no impact based on 6 or more studies. If there are 3 to 5 studies, then it can be what's promising, so there is a positive impact, but it's only based on a few studies, or what's not promising, there's no overall impact, but again based on a few studies, so you might want to do more studies, and then what we don't know is fewer than 3 studies. So you'll see most things are in what we don't know. Yes? So most things we just need more studies. But we do know that conditional cash transfers and health interventions, which includes both things like deworming, but also nutrition interventions, school feeding and so on. No, school feeding's here. But so health-based interventions do improve enrolments and attendance, and providing materials, which could include computers, it could include books, doesn't improve attendance. Moving along the causal chain, we do try and look at different outcomes along the causal chain, we have sort of measures of performance. Does a child progress to the next grade or repeat a grade, or do they drop out? And here, we don't know anything that works, doesn't work. So there's not enough studies measuring these outcomes, finding the effect to actually know what works and doesn't work. They're not measured that commonly. Where they are measured, it does seem that having additional teachers, additional cash transfers, school-based management, all these look promising. Small number of studies, but they seem to work. When it comes to test scores, interestingly, for example, conditional cash transfers, which seem to work, they do work on attendance and enrolments. They look promising for performance measures like this, but we simply don't know when it comes to learning outcomes. Not enough studies have looked at learning outcomes. The same is true for health. We've published in the 3IA Journal of Development Effectiveness a theory-based cultural analysis of CCTs and health, and you find a big impact on using health facilities, but actually no impact on actual health outcomes. So it only affects the proxy or surrogate outcomes, not the final outcome of interest. That might be because of lack of studies, but it might be because these things actually don't really work on the final outcomes of interest. And we need to know the difference. It's very obviously important. So there's actually only a couple of things. Ironically, materials work on improving maths, but not improving language. This is partly driven by computer-assisted learning. Computer-assisted learning, even when it's oriented towards language skills, which it's not normally, it's normally oriented towards math skills, seems to improve math skills, but doesn't affect learning skills. And you need to dig down in this to actually understand there's still questions here about what age group is it appropriate for, what sort of additional backup resources do you need for how computer-assisted learning to work, and so on. More questions we want to dig into. But again, the main point is, when it comes to test scores, we don't know mostly, because too few primary studies have gone to the final outcome that matters of test scores. That includes, for example, the deworming study. Didn't look at test scores. So what's different about this review that I've just been presented, we've really got a lot of disaggregation about different intervention types, which is not normally done. So we've dug down in those. And we have got more digital on process issues. We have looked a bit at the causal chain, but there's normal and effectiveness review. There's not a lot of it, but there's some of it. And then we've got what I referred to earlier, the extended friendly front end. We are producing, it's currently at the printer actually, we are producing a friendly version of this report, and the technical Campbell review is published separately. And we are doing an update, which will be available next year. So, thank you.
Want to take a round of 2 or 3 questions? To get some people who haven't asked yet.
Thank you. I was just wondering to what extent you're able to extend the analysis to look at different combinations of interventions, because presumably the policy question is not necessarily an either-or, but a bundle of interventions, and interventions working towards the same outcomes can be substitutes or complements. So the hygiene example, you may find that providing soap is more effective than some kind of behavioural change communication, but the policy conclusion is not necessarily to spend all your budget on providing soap, but it still may be that doing half and half is more effective if there's a degree of complementarity. Can
you introduce yourself as well?
Sure, I'm Tom from Oxford Policy Management.
I'm Dr. Chitranjan. I'm from Amalta, Asia. My specialization is on monitoring and evaluation. This is in fact a very interesting presentation from Mr. Ward, and I mean it's the matter of, I mean this shows that the range of issues and discussions it's presenting to a policymaker by, I mean, doing this lumping with subgroup analysis. But my concern is that for a particular, I mean, in the context of a particular country, if we are I mean, someone is looking at this systematic review, it's maybe for a particular program there might be some positive outcomes for majority of countries, but in the same program, if it is implemented in a particular country, it might not have a very positive outcome, or maybe in that case it is having a negative outcome. So in this context, what kind of meaning this signifies to the policymaker, and what he should do in this context? I mean, how he will apply this kind of systematic reviews to have any kind of policy setting goals in front of him. Thanks.
Thank you very much for this wonderful presentation. My question is also, I mean, somewhat like the gentleman who has just asked. I mean, how to remove the bias while selection of the studies? Suppose we are considering, like in the earlier studies, in the farmer field study, if we see that the training has been given to the farmers who are educated, only educated farmers have been taken, and we have seen a positive impact in that. And while we are reviewing, if we find certain type of studies and that has not been mentioned in our inclusion criteria before we start our review, so how does these type of studies give direction to the research, and what impact is it going to give to the policymakers further? So I mean, how we can be cautious while selecting these types of studies? Thank you. Myself, Dr. Supreet from PHFI.
Mine's kind of a broad question. It seems to me asking the right question is just the most critical thing. And whenever we do research, we do a set of questions, and we're doing log frames and all of that. But when you're looking at something like this, are there specific questions that one should be thinking of to narrow this down? So, and I just have two other very quick things is, sequencing, does it make sense when you're looking at, say, thousands of studies, to first narrow it down to the ones that are closer to the enabling environment and then start looking at it? Is there a sequencing issue to this? And the final question is the cost and the time of this effort. It seems to me there are cases where this kind of an approach may not be very effective. I mean, when you're looking at very pilot initiatives which may not have been tested on the ground before, or you know, if there are no follow-up studies that actually look at a timeline issue to see the sustainability of the effort. So is there any way to gauge the cost and the time of this thing?
Okay, thank you. So first question, Tom. So indeed, we'd like to be able to explore the issue of complementarity between interventions. That depends on evidence being there. So if we have lots of trials that are called what's called factorial designs in them, then the possibility of doing that is clearly quite substantial. So factorial design, you have two interventions, A and B, so it might be provision of clean water and hydrogen intervention. And you have 4 arms in your trial. So group A just gets intervention A, group B just gets intervention B, group C gets intervention A and B, and group D is the control group, no treatment control group, if you have one. And so then you can see where having A and B combined actually has a bigger effect than just doing A or just doing B, or indeed A plus B, so there's some synergy between A and B. Or whether the impact is less than A and B, so there's some substitution in the effect. In the water supply sanitation, there is, if I remember correctly, only one, there might be 2, proper factorial designs that have looked at this. The other way you can look at it is, of course, by comparing the average treatment effect across interventions that are combined compared to single interventions. And when we do that, it's very interesting. So the overall impact of water quality studies, water quality interventions on child diarrhea is between 40 and 60% reduction. The overall impact of hydrogen interventions is between 40 and 60% reduction in child diarrhea. The overall impact of combined water quality and hydrogen interventions is between 40 and 60% reduction. It's no different. Is at odds with our theory of change, and it might be because we have a very small number of studies in the combined category. But it's something we'd like, therefore, to know more about. So this question about, well, what can I do of an SR, because I want to know about how it applies here in Rajasthan, not how it applies in the world in general. And you put this as being a question about context. And so when I first came to this field, and I appreciated this point, and I thought, well, this, of course, again, is a difference between us and medicine, because in medicine, it's a drug is a drug is a drug. And so they can easily take results from SRs and just apply them. But one of the Bibles of evidence-based medicine is a book called How to Read a Paper. It's an extremely good book, and I recommend it very highly. And the first page of How to Read a Paper is, a doctor doesn't want to know if a drug works in general. He wants to know if it will work for the patient sitting in front of him right now in his chamber, in his office. And so it's exactly the same challenge. As I mentioned earlier, a lot of drug trials are done on college students, but your patient is a man in his 50s or 60s. And so you want to actually know, will it work for me now, here and now? And this is the fundamental challenge in generalizing from primary studies, external validity from primary studies, but also in drawing lessons from SRs. And I do believe there are two answers to this. And one is an understanding about context. And that is understanding about context in the right way. There's a general view out there, I won't say where there is, but there's a general out there, that RCTs, for example, have good internal validity, but have very limited external validity. Whereas thicker studies, as they're called, thicker studies, like anthropological studies, are very good because you've got a lot of context and you can generalize, but that's the advantage of them. That is not necessarily so. There's a very nice paper published in Journal of Development Studies last year called Why Were Social Scientists So Wrong About the Green Revolution? Now, if you're old like me, you'll know that back in the early 80s when I was an undergraduate, all we were reading was papers about why the Green Revolution was bad, what a bad thing the Green Revolution was, and how it was going to impoverish vast swaths of Indian society and South Asian society. This was untrue. This was wrong. Okay? So why were social scientists so wrong about the Green Revolution? And one of the main arguments is they relied on village studies. Village studies I'm a big fan of village studies. They're very good, very thick information, but they're not representative. And once we started to have representative household surveys of what was really happening across India, across Bangladesh, across Pakistan, we saw, hey, living standards are increasing enormously in villages where they've adopted Green Revolution technologies. And so it's not necessarily so that the context you get in thick data allows you to have a higher external validity. I would say village studies have very high internal validity, but the external validity might be very limited, as in case of mispredicting what the effects of the Green Revolution were. So it's about using that context sensibly. So you say, where were the studies done that find this particular effect? Is my context similar? And you have to understand the parameters in your context that influence study outcomes. So we are getting quite deep into how studies are done. And it's one of the criticisms we have of the primary studies that we finance and the SRs that we finance. They don't go enough into context and actually using that context. So we tell all of our primary study authors, you have to explain the context, you have to explain the intervention, you have to explain the theory of change. And they're starting to do that because they won't get their final payment if they don't. But they don't actually link the bits together. And that's what you need to do to really understand, will this apply to me? Well, where was this other study done? Was it a similar context in terms of the variables that mediate the outcome? And if it was, then I can apply it. If it wasn't, I can't apply it. You don't need to always do a new study every time. You can learn from evidence from elsewhere. We do want more studies, so I want you to do a study as well, so we can add to the evidence base, but you don't need that to make your decision. So this also came to your question about the bias, what you called the bias of the studies you've included. So studies aren't included on the basis of the context. We include them all based on whether they have valid inclusion criteria or meet the inclusion criteria or not, based on study design. Now, if we had thousands of studies that we thought would meet the inclusion criteria, it would be very sensible to do a systematic review of the effect of this program in South Asia, or in India, or in Kerala. Yes? You could narrow it down that much. But just as in clinical trial SRs, they do look at the impact of particular treatments in particular subgroups of patients. But we don't have that luxury. because even if we do a global review, across low income countries, we still only have a handful of studies to synthesize. So restricting it would rule out evidence that might be useful. So I was having conversations with DFID a couple of years ago about a possible South Asian systematic review program, and what came out of those discussions was that the idea would be the questions would be relevant to South Asia. Not that the evidence would be looked at would only be South Asian evidence. We'd be throwing out stuff that probably you'd want to at least try and draw on. Asking the right question is absolutely right, and there's a few aspects to that. So 3IE has helped manage studies for a number of agencies, starting with DFID and another AusAid. We did a call of over 60 SRs for those two alone, but also USAID, MCC, CEDA have all financed SRs that we've managed. And when you go to the agency, when we started with DFID, and we say, okay, what's your question? They would say, we want to have world peace and eradicate global poverty. How do you do that? And yeah, we want to know too, but that's not really one question. It's really to split up a bit. So, okay, so let's have one review on ending global poverty and another on having world peace. Still a bit broad. So you do need to narrow the review question down and make it really quite precise. So actually, something that came up earlier was, do you define your review by intervention or by outcome? So how do we achieve female empowerment, which would be hopelessly broad? That would be an outcome-oriented question. Generally, we don't do that. Generally, we do intervention-oriented questions. So what's the effect of, say, self-help groups on female empowerment? Still pretty broad, but it's something that would be manageable. We have got one on microfinance and female empowerment, for example, that's just coming out. There was also this issue about context specificity, and now I am getting quite technical on this. To me, the issue there, and I think actually it relates to your question as well, is what I referred to as earlier, the horizontal synthesis in the causal chain, in the evidence matrix. And we haven't done much of that, and we're starting to produce some studies that are doing it. So when you've got the evidence you have, you piece it together intervention by intervention in your evidence matrix. And this can be quantitative or qualitative evidence. And then you're summarizing across the horizontal synthesis for each particular intervention. And once you've done that, you can identify subgroups based on the causal narratives. And part of that, the subgrouping you're making, will be context specific. Now, I haven't got examples to tell you about because we're still trying this out, but I believe that's what's going to happen. But to give an example from farmer field schools, and to generalize a bit, we're doing a separate paper on targeting farmer field schools where we are using this methodology. And basically, farmer field schools participants are more educated, have more land, are wealthier, and they're men. So if you're targeting for farmer field schools is we want to target wealthy men with lots of land, it works. If your targeting is we want to target poor women, it doesn't work. Because those poor women don't participate in farm and field schools because they haven't got enough land, they're obviously more risk averse, they don't have time to go and participate in these participatory farm and field school classes, and they're less educated. So we're piecing together these narratives around the different causal chains we see. Final question on cost versus time. So when we started, we were hopelessly optimistic. And the first round we commissioned, Hugh mentioned, review round 1, the average cost of study was $20,000, and the average length of time was 6 months. That was, as Hugh mentioned, that call went out in September 2008, so the awards were made in February 2009. 2 of those reviews aren't finished yet, and they've tripled their budgets in the process. Yes. So the education one is one of them. That's actually just been published. So we were hopelessly optimistic. We now say a review costs around $80,000 and takes 18 months. And that's a basic effectiveness review. If you're going to go ahead and include the causal chain analysis, it might be 18 months if you have a larger team, but if you're going to really do it, it's probably looking more at 2 years. So the original idea we had of doing SRs to identify the gaps and then do commission primary studies to fill those gaps, we didn't have any SRs, so we couldn't do that. AusAid, for example, that was funding part of our reviews, they got very disillusioned with this. And they thought, well, this is just taking too long and it's too costly, it's not responding to our needs. So there is something called a rapid evidence review, where basically you cut down on the search time. Rather than spending 3 months, you spend 1 month. And we plan to do some studies as a rapid evidence review and then do the full SR and see the extent to which there's a difference in findings. We hope to do this for a number of studies so we can start to generate evidence about whether you need to do a full SR or whether you can do a rapid evidence review. DFID is experimenting with a range of evidence products, as are we. We're starting to commission other sort of evidence products. There was one other thing I was going to say, but luckily for you, I've forgotten what it was.
Great. Thank you very much, Howard. Thanks.
Our final speaker is Ruhi Saith. She will speak to us about the Cochrane Public Health Satellite. Ruhi is a senior consultant at the Oxford Policy Management, working on health as a part of social policy team, and has recently been involved in setting up a satellite of the Cochrane Public Health Group for the South Asia region. Welcome, Ruhi.
So, well, good morning, everybody. My presentation is going to be much less intense than the previous sort of dense systematic review presentations. So you can just relax and sit back and just listen to the story, as it were. So I'm going to be talking about the satellite of the Cochrane Public Health Group, which has recently been launched here in India. And towards that, I'll give a bit of a background of what exactly Cochrane is about and how that links to systematic reviews, what are the different sort of initiatives which exist in the context of systematic reviews, and then narrow down to the launch of this satellite. Before I go into that, just acknowledgements of people with whom I've been working and who've played a role in establishing this satellite. So the main headquarters of the Cochrane Public Health Group are located in Melbourne, and the coordinating editor there is Liz Waters, and the other people who've been involved are Jodie Doyle and Rebecca Armstrong. The satellite is currently physically located in Manipal University, and Sri Kumaran Nair is the other person with whom I've been working on this. And then, of course, all the support and backing from Oxford Policy Management, which has also offered to play a role in extending the satellite in its South Asia. Just a screen. Oh, yes, sorry. And Tom, who heads the Delhi office of Oxford Policy Management, is here. So these are the main people I wanted to acknowledge first. So as I said, I'll first give you a bit of a background about the Cochrane collaboration itself, what the Cochrane Public Health Group is about, and then finally come to the satellite. I think it was Hugh who earlier said that systematic reviews basically started off in the social sciences in the US. Now my understanding of it was actually, and then he said that it came on to medicine after that. Now my understanding of it was the reverse, but that might just be because being a medical person, I know more about the medical world, and I'm sort of biased about it and think that systematic reviews entered from the medical world into social sciences. Or it might also be the case that it started off in social sciences but then sort of died out and then was reinvented in a sense from, you know, or got reinvigorated from the medical world. But as far as the story that I had constructed was that this whole sort of area of systematically reviewing evidence started off mainly in the UK, and it started off with the NHS, or the National Health Service, playing a very important role. So as most of you might be aware, the health system in the UK is quite a linchpin of the social policy and social welfare there. And one of the issues was that this health system was basically putting into practice what we're talking about in India now, about universal health care, which is affordable to everybody. And the state funds it and people get it free of cost. But of course the issue was that a lot of the treatment which was being offered was high cost, and there was the question of sustainability and of having adequate funding, of trying to make sure that there's enough value for money. So it was around this time that Archie Cochran, who was a British researcher, came on the scene and began talking about how he felt that a lot of things which were being implemented in the NHS were being done without any actual evidence backing it, and felt that there was a great need to, whatever was being sort of applied in terms of treatment protocols, that it should be backed by relevant trials. And being the world of the clinical world and medicine, a lot of emphasis on randomized control trials. And it was sort of, this started off the whole movement within the NHS of trying to apply things based on evidence. And in the 90s, somebody called Ian Chalmers in Oxford basically launched what was called the Cochrane collaboration. And the idea there was to bring together evidence from a number of clinical trials, because there used to be a number of trials which had been conducted on the same drug. And while there would be some trials which would say that it had worked, there were a lot of others which said that it didn't work. And all this was a bit sort of biased because of drug companies as well, which funded a lot of trials. And then if the trial worked, then of course it was published and was given a lot of prominence. And if it didn't work, then the chances were quite high that it was tucked away in the background in the cupboard somewhere and just didn't surface out. So Ian Chalmers came up with this sort of collaboration, which was a collaboration of voluntary researchers around the world who would contribute their time and effort and voluntarily try and put together this evidence which existed, and making an effort to make sure that it was not biased. Now, this will start going into the methodology of systematic reviews, which Howard has already talked a bit about, so I won't go into the methodology of systematic reviews. But the idea was to try and put together this evidence in such a way that it was not biased, and it would try and sort of bring out the existing evidence or the gaps that existed. And basically it was meant to apply to clinical trials and look at the effectiveness of drugs. And that started off in the early 90s. And it eventually resulted in what was called the Cochrane Library, which started publishing all these results. And this was mainly in the clinical world, in the medical field. And this was extremely important to doctors. And then it also led to a number of institutions, like in the UK, there was the National Institute of Clinical Excellence, NICE, which then uses this evidence and develops guidelines for the NHS, which are then put into practice. And it has sort of resulted in, there are many examples which I don't have time to talk about here, especially in the field of cardiovascular medicine, and where earlier, although evidence existed, it was not being put into practice. And with these systematic reviews, a lot of studies came out which showed that there were particular sort of drugs which were actually making a huge difference, and then that got implemented, and that has resulted in saving a number of lives, and it has made a huge difference on the field, as it were. And the Cochrane Library is now sort of quite commonly used by doctors everywhere. And even in India, we now have access to it free because the ICMR has funded this. So the Cochrane collaboration basically is quite a huge international collaboration, and it has a sort of central steering group, and it expanded quite a bit and became quite international. And the main feeding ground for the literature and the evidence which comes out are the review groups. And basically there are a number of groups which are focused around health problems. So there are 51 groups, most of which are clinical groups. So you would have like the heart group, the skin group, the injuries group. And what these do is produce reviews. And there is a sort of base, editorial base. So a lot of support is given to people who are producing these reviews. And as you heard, these reviews can be quite intensive. And often it can be a labor of love. So it's people who are really keen on that particular topic, who are really interested in it, and who are quite nerdy, you know, and enough to sort of sit there and chip away at the evidence and try to put it together. And so they are sort of working away on this. And they need a lot of help as well. So you have these editorial groups who are providing this help in terms of help in the methodology as well as in providing studies. That is a sort of key gap which we face when we're trying to do these systematic reviews in developing countries. And then you have these Cochrane centers which are located regionally, and they are sort of supposed to help in terms of providing a bit of support and some sort of link to governments as well in trying to promote the use of this evidence in policy. Now coming to the public health group and how that came about. So with the whole Cochrane collaboration, a large part of it was focused on clinical studies. Now gradually there was a realization that there were a lot of public health studies which were there in different groups. So in the respiratory group you would have a lot of studies looking at interventions related to tuberculosis, for example. Then in case of clinical conditions like vitamin A deficiency, you might have a lot of nutrition based studies. Now a lot of these were related not just to looking at the efficacy of the particular medical intervention, but there was a lot of role for other kinds of interventions as well, which might be more community based, which might be more sort of directed to populations, which might be behavioral. And the realization that when you're looking at those kind of studies and you're trying to put together the evidence for those, the kind of methodological issues which arise would be different from what is faced when you're looking at clinical studies. A lot of the clinical evidence was from studies which had sort of the same intervention, the particular drug, which then may be slightly varied in terms of the dose of the drug, but largely the same intervention, largely similar populations, largely looking at same outcomes. So if you had a particular drug which was looking at hypertension, then treatment of hypertension, you would basically have as the outcome the impact on maybe the diastolic blood pressure or systolic blood pressure. So you would have very sort of similar outcomes. Now in case of public health, there would be a lot of differences in the kinds of interventions that are implemented. Also it's at the level of the population, and you would have a lot of qualitative stuff in that, and the interest in most cases would be not just in the outcome and whether a particular intervention works, but also looking at how it works and what are the contexts in which it works. So there was a sort of realization that, you know, with public health, you need different approaches. And with the Cochrane collaboration, a set of guidelines have been developed when you're doing systematic reviews. And you're supposed to sort of follow particular ways of identifying studies. You're supposed to follow very strict guidelines about the kinds of studies that can be included, which typically means that you're allowed to include randomized controlled trials. And there are particular criteria. Now, it's very difficult to stick to just randomized controlled trials in case of public health, obviously. So there was a growing sort of need for a different approach to putting together evidence from public health studies. And that then sort of resulted in a separate public health group as such forming. But there's a series of processes which happen before a group can become independent. And finally, in 2008, a public health group was registered. And these are the details of where it is located. And so the scope basically of topics it deals with are those which are at the broader level of interventions, population level interventions, and generally targeting distal determinants of health. And this became sort of even more popular, and the need for the public health group began being realized when this whole Commission on Social Determinants of Health released its report, showing how what was important is not just the sort of immediate proximal level interventions, but more broader distal level interventions, like for example interventions at the levels of say poverty reduction and things like that, or employment, working conditions, which play quite a role in more proximal interventions which then have an impact on health. So the public health group sort of deals with a wide range of topics which are basically at this distal level. And these are some examples of the topics that we've been looking at. Now at the same time, the Cochrane collaboration has kind of a twin body, which is the Campbell collaboration, which has been dealing with systematic reviews in the area of justice, education, and that collaboration has more of a broader methodology looking at qualitative interviews and qualitative methodology and things like that. And gradually with the public health reviews, it sort of, I think this idea sort of started moving more into the general development field as well. And DFID also began getting more interested in the idea of systematic reviews and trying to systemize this evidence. Because there are a lot of development interventions which for which evidence might exist, but then a lot of duplication happens. And also, while the context might be different, it might actually be possible to apply some lessons from other interventions to interventions which are being implemented. Of course, there's a huge body of literature and a lot of people who sort of oppose this whole move and talk of how maybe in the clinical world this makes sense, but given the heterogeneity of studies, given the heterogeneity of contexts, it's not really very useful in development. So that's a completely sort of big discussion in itself. So it's certainly not controversial, but there are lots of people who do support the use of systematic reviews in development. And apart from its use and effectiveness, there's also the fact that it brings together this whole body of related literature, which if anybody wants to do work on a particular intervention, you identify a systematic review, and that gives you immediate access to a whole range of literature then you can look at and find out what's been going on in the field anyway. Now, when the public health group was launched, intentionally at the time, certain decisions were taken, which was that a lot of the work done by the Cochrane clinical groups has been typically working on high income country kind of related issues. And most of the drug trials at that time, while the focus has now shifted more to developing countries, but at that time most of the drug trials were being done in developed countries. And most of the systematic reviews which were being produced were from developed countries. So the idea was with public health interventions that we specifically wanted to make sure that there were lots of studies which would focus on interventions which were relevant to low and middle income countries, and to try and involve researchers from these countries. Because naturally, if you have more researchers from those countries, then the chances are also that the kinds of studies that are looked at, the kind of topics which are looked at, the scope of those topics would be more relevant to these countries. Now, as a way of trying to promote this, we felt that having a satellite of the Cochrane Public Health Group in a developing country would be quite a good idea. Also in terms of being able to not just attract researchers from these countries, but also to create, to generate evidence of reviews and how they could be used. And as I said already, to make sure that more topics which are of relevance to developing countries are then taken up for systematic reviews. The question then arose of where the satellite should be. And there were two of us on the Cochrane editorial board in the public health group who were from India, myself and Shri, and we were quite interested in this. And at the same time, a number of institutions were coming up, and there were a number of studies in India which were beginning to show that we had a huge gap of public health professionals. And at that time, I was based heading the research group at Public Health Foundation of India. So the main mandate of the Public Health Foundation at that time was, and I think still continues to be the case, although it hasn't taken off, to increase the number of people who were trained in public health. And that would mean that there would be a lot more people and a lot more sort of happening in public health in India. A number of other institutes also were launching degrees in public health. And we felt that the time was ripe in a sense, and there was a lot of interest in India in public health. And we did some initial groundwork and found there were lots of institutes who were willing to, and felt the need for this. So we thought of exploring the idea of having it in India. And the initial activities for the satellite were basically in the area of systematic reviews, trying to build up capacity and training. And there is something called the South Asian Cochrane Network, which is in Vellore, which mainly deals with clinical training. So we felt that we would focus on sort of public health related building of capacity, and then try and identify some key questions of relevance to the region and try to get some reviews off the ground. It then became slightly wider because in Melbourne, the public health group's work is actually located within a wider evidence-based kind of research group, where they not only look at systematic reviews, but they also look at primary studies and trying to improve the evaluation methodology. And then, of course, trying to use the results of this for influencing policy. And so we thought that it might be not a bad idea to actually house this systematic review satellite within a broader umbrella, and that's how this broader umbrella of public health evidence South Asia kind of came up. And at present, we are sort of trying, so the Manipal University has launched it, and in fact, Dr. Srinath Reddy officially sort of launched the initiative 3 days ago. Now, in terms of what we are trying to do there, it's mainly mentoring and things like that. And we've been trying to talk here with DFID and with 3IE, which also works in similar areas. And OPM has been supporting a lot, especially because we have offices in other countries in South Asia. And this is supposed to be really a South Asia initiative and try to involve researchers from other South Asian countries as well. So we want to have these similar 3 prongs of systematic reviews as well as promoting primary research and linking to policy. There are, of course, a number of challenges, mainly trying to get people involved, trying to raise awareness, trying to get sustainable funding, establishing links, and very importantly, ensuring that there is complementarity and not duplication. Because even today we can see that there are people who are like, there's JPAL, which is working on evaluation methodology, there's 3IE, which is promoting systematic reviews, and also, you know, bridging the gap between evidence and policy. So ways in which we can work together and make sure that it's complementing different complementary roles are sort of towards the same objectives. And so what we need from you is basically ideas on what you think will work, especially in the context of Delhi, and what do you think people like you who might be interested in systematic reviews would need from this satellite, and what are the kind of things that we can give you which would be helpful for you, and then of course your participation. And if you need further details and you want to join the mailing list that we are developing and launching a newsletter, then do get in touch, and we'll be happy to provide more details.
Great. Let's have a round of questions for Ruhi on the Cochrane Asia satellite, if anyone has any. I guess, Ruhi, I've got. Do you know what the first few initiatives are going to be? I know you just launched officially 3 days ago, but do we know, at least in 2013, what's kind of on tap?
So the initial ones are going to be sort of initial workshops on basically raising awareness of systematic reviews, and you know, what systematic reviews are, what they are useful for, and things like that. And then some kind of basic training. And so Manipal has already sort of established contacts with few organizations and identified few sort of people within those organizations who are interested in systematic reviews, and then try and give them some basic training. And then also identify some key topics of relevance to India, and then try and get funding for those topics, so that people who are interested in systematic reviews basically learn while they are working on those particular topics. So we're in the process of identifying that, and so beginning initially with the systematic review part, and then gradually sort of building the other prongs as well.
Any other questions for? Do you have any other questions for Ruhi at this time? So we've got around 15 minutes for kind of general question and answer period on systematic reviews. I guess I'd like to take advantage of actually holding the microphone and ask the first question to both Howard and Ruhi. So a big point of the systematic review is that we do need more primary evidence and primary studies, but we're starting to amass an evidence base that's certainly better than it was, 5 years ago or 10 years ago. And the point is, how can these high quality studies then, become more relevant for policymakers, and doing some of that front end work as a public good. so policymakers can have a sense of, a general sense of what the evidence is. Do we have examples either from the donor community or from developing countries where policymakers have come to 3IE or come to Cochrane to better understand the review, or basically in another way of put a review into practice in terms of either how they fund or the types of programs that they're initiating? How is that kind of dialogue between 3IE and Cochrane and different policymakers?
Okay, thank you. Sadly, at the moment, I don't think we can point to any very clear examples where review has had very clear policy implications and resulted in policymakers adopting change in policy as a result of that. In the same way, you can certainly point to that happening in medicine since Cochrane. I mean, Cochrane was the foundation of evidence-based medicine, and prior to that, doctors used to base their prescription decisions on what they learnt in medical school 20 or 30 years earlier, which was clearly out-of-date information, or what colleagues told them, or most importantly, what drug reps told them. Yes, and so the advent of evidence-based policy making, which, as Ruhi said, particularly in the UK, is policed by NICE. NICE decides what treatments are available under the NHS based on cost-effectiveness analysis. And barely a month goes by, but it's not criticised in the press in the UK, because the press says, so-and-so's granny died because NICE wouldn't allow the hospital to use this treatment, but it's not cost-effective. The resources are not unlimited, and so those decisions have to be made and are being enforced by NICE. So there clearly is evidence-based medicine going on. In developed countries, in another area of the use of evidence, I've actually just blogged on this recently, in the US, but particularly UK, is policing. So there's been a big increase in evidence around policing, different ways of hotspots, so policing hotspots, so you identify areas with high crime and you focus your police resources on those. In fact, my most recent blog on 3i site is that the other week the police police across the UK were criticised in the press for not investigating nearly 100,000 crimes a year. And the police just make a decision. We know based on experience that there's no witness, there's no evidence, we have a low success rate in these crimes, so let's not waste resources on investigating those crimes, let's investigate those where we think we might have success. Now, I had, a few years ago, my car was broken into on Christmas Eve, all the Christmas presents were stolen. It was upsetting. The police did nothing about it. It's upsetting. But I understand they were never going to catch the people that did it. So what was the point in doing anything with that? And so the police do make these evidence-based decisions in some countries, like the UK, to inform policy. And it's very good. It's a good thing to do. So we don't have that situation yet in lower middle income countries from systematic reviews as you do in some other places. In South Africa, I would point out, as a country where in the presidency there's quite a high awareness of the point of evidence, and they are interested in engaging in both systematic reviews and rapid reviews, being commissioned to answer the questions they are interested in. And so we do see in Mexico, where you have an organisation called Conaval, which is responsible for use of evidence informing government policy and spending patterns, based largely currently on primary studies. Conaval's also asked us about training on doing systematic reviews, so their staff can do reviews of existing Mexican studies. And interestingly, Uganda has just launched a database of all the evaluations they have of programs in Uganda on the website of the Office of the Prime Minister, and South Africa plans to do the same. And this will allow us to do systematic reviews of programs just in Uganda. They wouldn't be effectiveness reviews, there's not enough studies. If you want to do a full causal chain analysis in particular sectors, that will help a great deal, because a lot of this stuff is grey material you wouldn't have otherwise been able to access. And so the fact that these governments are starting to take those steps, I think, are steps towards certain parts of government being more willing to look at evidence. The bad thing that happened in many countries was the misinterpretation of the results agenda. So the results agenda, which is we're going to manage by results, not by just how much we spend, good thing. And the MDGs internationally gave a big push to the results agenda, and many governments took that on board and started to do more results-oriented plans. Now, it's not true in India, where you had already the system of 5-year planning, but there was also more focus on performance measurement and trying to measure by results. And the problem that happened was the results agenda got hijacked by outcome monitoring. And people thinking simply monitoring your outcomes was sufficient to know what impact your programs is having. And that is not true. You need to have impact evaluation of your programs to know what impact they're having. Just looking before versus after of outcome monitoring will not tell you what difference your program made. And so there's a lot of wasted effort gone into putting in place outcome monitoring systems in these results-based management systems. They're not going to actually be helpful for improving performance. And so governments have actually had good intentions, and they've been misled by the UNDP and the World Bank and people. They've been putting them into outcome monitoring systems. So we need to get them out of that and get them into doing impact evaluation. Ruhi.
So I was sort of going to say some similar things to what Howard said, which is that in the clinical world, certainly there is no doubt that it has had an impact, these systematic reviews. But then again, even in the clinical world, like for example in the UK, because there is this huge sort of central point through which you can regulate. But say, for example, in India, with the huge private sector we have, not just with the huge private sector, but the fact that even in the government sector itself, in government hospitals, we don't have any regulations. So it's very difficult to have any protocol-driven common treatments across the country or even across states. So in that case, then even if evidence exists about what might be most effective or cost-effective, then implementing that has been a huge challenge. So unless central sort of systems exist to be able to enforce that, it's difficult. And with regard to other development sectors, the impact of these systematic reviews, I just finished a systematic review earlier on slum upgrading interventions and their impact on health. And it was quite amazing because being a researcher, I had written this sort of really boring Cochrane systematic review, which at the end of it, I was getting bored to read it myself. And then when it got published, this huge machinery swung into action from 3IE. It was funded by 3IE, as well as the Cochrane Public Health Group, where they had people in place who were actually taking care of communications. And I was amazed at how they came out with these lovely one-pagers summarizing the results and, you know, extracting the main points and making it so easily accessible. And then they sent it to me and other co-authors who were there to make sure that they captured things right. And in most cases it was, except for some, we sort of added some boring qualifications and things like that. But with that kind of effort, then they sort of had this whole list of people who were stakeholders. And then when you do a review, you also have a review advisory group, which had a lot of people from policy as well as from the field. And so they took names from us of people who had been advising us and themselves did a lot of research of who they should be sending this to, different government departments and different sort of people who were relevant, and then started disseminating these results. And I was really amazed by that whole effort, but that effort, I hope, will sort of yield some results. But without that, I don't think most people are going to really bother reading these dense reviews.
Great. Dude, just a list of questions, or does anyone else have any questions? Why don't we, I'll come to you in a sec. Just back here first. I guess while it's going back, I think one thing which will be interesting to see, at least in South Asia, I know the India context best, is if certain government groups or quasi-government groups will kind of be able to have the capacity to kind of take these systematic reviews on board, at least in terms of understanding the evidence. So if that's done by Public Health Foundation of India, or the Ministry of Rural Development sets up this concurrent evaluation group, concurrent evaluation office, if those offices would then be kind of places that, you know, would be natural customers for systematic reviews.
Hello, I'm Avik from Duom the World. My question may be a bit out of track, but I need this clarification that it's for all the evaluators. After any evaluation, let's see if the result is a negative. Okay, then what's next? what's the role of the evaluator then? For example, like what I've seen in the FFS program, the neighbors of neighboring farmers were not actually quite educated. It's like it's no effect on them. So is it possible to educate all the farmers in the world? So it might be some process so that the educated farmer can transfer their knowledge to the uneducated or non-educated person. And the second question is that, as I'm a basic researcher, we always depend on the evaluation made by this Cochrane and all the leading evaluators to validate our research. So is there any way to validate the evaluators, the evaluation results? Because depending on the evaluation results, it has a great impact on the basic research. Sometimes, like if any negative results are there, maybe a very good research may be stopped. Maybe the funding is stopped due to that result from any of the leading evaluators. So what's the process of validating that evaluation, that whether it's going in a right manner or right?
Thanks.
Okay.
Any other questions from Madhumita? I'll get to you in a sec. Anyone else? Cassie?
Hi, I'm Cassie from Catholic Relief Services. I'm just coming at this as a development practitioner rather than an evaluator, and I'm wondering, just maybe to take advantage of you being here and having done all these systematic reviews, I wonder what your impression is of NGO evaluations. As an NGO that's putting a lot of investment into improving our evaluations, just what do you, kind of more of an opinion question, what are you seeing as the quality of NGOs and NGO evaluations? My guess would be that maybe a lot don't meet up to your quality criteria. Is that true? What are your common themes that you're seeing across the board, and what would be your kind of recommendations in terms of the NGO sector and where it's worth really investing in impact evaluations?
Yeah, I just wanted to ask, because we usually, like our regional director wonders, like when country directors have to trained on M&E or systematic reviews, different countries where we are working in Asia. So we think like we don't know much like where we can go for training them like at an international level. So on systematic reviews and M&E, if there are some organizations or anything who can train them like in different Asian countries, that I would like to know.
No, it's just a comment that Dr. Saith made, and it's a follow-up on that one. The more we look at the whole sort of development process on the ground, what we find is, sometimes what works and the results will show you what works, but it's the protocols and processes that are followed. And what I'm kind of curious is, both in terms of RCTs as well as these SRs, how much of that process can you capture? Because if that's not followed, you can have the same kind of interventions but come up with completely different results. So how do you actually address that issue?
Howard, I'll pass you first, and then Ruhi after that.
Okay, thanks. So on the first question, I'll just take the first point, but I wasn't entirely clear of the second question. This is a problem for evaluation and systematic reviews. What do you do with what we call negative findings, which includes, we say negative, actually mean no impact from the program as well. If you've done a good quality, what we call theory-based review or theory-based impact evaluation, so you've embedded the causal analysis, the effectiveness analysis, in a broader process analysis of the causal chain, well then you hopefully have some understanding why the program's not working, and you can make some conclusion as to these are ways in which the programs would work better. And so the recommendation is not, oh, this program doesn't work, close it down. It might sometimes be that, but it might be, we believe that by making these changes in program design or program implementation, the program will be more effective. They they probably are just beliefs. They're only evidence-based if you know in some areas programs like, actually came to the last question, in some areas the program is done in manner X, in other areas done in program X manner Y, and it works in X, not in Y. Then you can say, well, it works in X, not in Y. But if it's done everywhere in X and it doesn't work, you can say, well, we think based on the logic of the program, if you fixed these problems, then it would work. But of course, you don't know until you have evidence of doing it that way. So, of course, in India, NGOs are everywhere. So, in our office here in Delhi, 3i's office here in Delhi, our hospitality assistant, our tea lady, we call them in England, is the president of her own NGO. Yes, so it's not surprising in Indian context, even the tea lady has an NGO. And her NGO basically collects clothes and blankets from middle-class households and takes them to poor households during the winter, and it carries out immunisation programs in the slum areas. And this is when we first started here, so 4 years ago, I'd been asked to write a piece on a US website where Charity Navigator, this organisation that rates for different charities, was proposing to look at the impact of NGOs to rate how effective they were, not just looking at their accounts, basically, not just input measures. And a lot of NGOs were saying, well, you can't do that. What we do is intangible and unmeasurable, and it's not possible for NGOs to quantify their success in that way. Charity Navigator shouldn't do that. And so, at the same time I was being asked to write this blog, I went to visit Clara, that's her name, Clara's NGO. And when I went to visit Clara's NGO, they showed me their quarterly performance reports, which were simply numbers of people they had immunised and money they had collected and how many blankets they had distributed and so on. So it was process monitoring, but that's an NGO, an annual spend of $7,000 or something. That's appropriate for them to do. So I'm not for a moment saying everyone has to do an impact evaluation. You have to do your monitoring evaluation tailored to your needs and the evaluation questions you have. And so a lot of the time, what you want is a good process evaluation. What you want is simply monitoring data. It depends on, I think, partly your scale, but partly the questions you want to answer. But of course, for larger NGOs doing larger programs, taking large amounts of resources, you have to be able to answer the impact question. For smaller NGOs, you're probably doing programs other people are doing. It would be good if you can inform that design by looking at evidence elsewhere from primary studies or reviews. But for larger NGOs, you have to be commissioning impact studies. And it is the case that most NGOs, most M&E and NGOs, both international and national, come out of a qualitative evaluation background, and they are very wedded to these approaches and can be quite resistant to more quantitative approaches. What you see from the experience of JPAL is actually it's for national NGOs like Pratham, which have been more open to using the quantitative approaches, and they're not working so readily with Oxfam or CRS or Save, that children's a bit of an exception. That's starting to change. So you won't find many impact evaluations of NGO programs, including SRs currently, if they're looking at the effectiveness analysis. If they're looking at other steps in the causal chain, they may be included, but actually they may not. When we were doing our horizontal analysis and filling in the cells with different studies, it's surprising that you find papers written up, reports written up, you can't even tell what program they're evaluating. There's so little information actually contained in the report. Actually, they say, we're looking at this program in this place, and well, was this particular program? You can't even tell. Training is a very factual question. So the Campbell collaboration does provide training to do systematic reviews. The training is usually free, but you have to get to where they're doing it. We did actually 3IE joint with Campbell and BRAC, was it BRAC in the end? Yes, BRAC University Public Health School ran an event in Dhaka last December where we had workshops and training sessions. We won't be doing another one of those that soon. There was a project financed by DFID that did training in South Asia, including 2 sessions in Delhi. Whether they'll continue that or not, they're still discussing. I'm not sure if the Cochran Public Health Group are doing trainings. I think Ruhi did mention workshops, so she can talk to that. The final question. So this is actually crucial. So earlier this year, I had an operation on my knee, an arthroscopy. And so as I do when I have a health issue for me or my family, I go to the Cochrane database. I do believe in systematic review. So I go and look at what's the evidence say. And the evidence for doing physiotherapy after having an arthroscopy doesn't work. There's no difference in the flexibility you have in the knee that's been operated on 12 months later when you do physiotherapy or not. Okay, so I read that before I had the operation. I thought, okay, fine, that sounds like it's not worth doing. Then I had the operation and I went to the doctor told me, okay, now you do these physiotherapy exercises. And one is you have to sort of straighten your knee and push it down like this, and you repeat that 20 times. And the other is you have to sit on the edge of a table and bend the knee up inside you, and repeat that 20 times. And the other is you lie down again and you twist the knee over like this down flat, repeat that 20 times. So you're doing these 3 different exercises, 20 times each, and you do that 6 times a day. Well, I've got a job. I haven't got time to bug around my knees 6 times a day, okay? It's not going to happen. So I think compliance with these exercises is probably quite low. And unfortunately, the review the trials are looking at didn't have data on compliance. So if we had an efficacy trial, maybe these exercises do work. If you actually stick to doing them 20 times, 3 times, 6 times a day, it works. But if you actually don't, you just like when you're lying in bed, okay, I'll do a bit of this, you're doing it once or twice a day at best, maybe it doesn't work. And so getting this data on the intermediate steps in the causal chain, like compliance, are crucial for actually understanding the results.
I think Howard has sort of largely addressed most of them. I'll just try to fill in parts where I think he may not have. With regard to your question about the quality of, if you're talking about primary evaluations, and if a particular evaluation shows that something doesn't work, and then how do you assess the quality of the evaluation? Now, when we are doing systematic reviews, at least with Cochrane reviews, there is a particular sort of guide to try and assess the quality of the primary study and to see whether it satisfies certain criteria and therefore whether it can be considered as being good in terms of internal validity, in terms of external validity. So there are certain sort of checklists which you can use to see and assess the quality of primary evaluations. With regard to training, I don't know whether you are also asking about training for evaluations, or it was just training for systematic reviews. So with the public health group, that's part of the plan to try and have some more regular kind of trainings. So that sort of schedule and funding for that is we're trying to get it at the moment. So it's not yet been established, but that's the sort of plan basically. And with process, with capturing the process, now that's one of the problems with Cochrane reviews, because they are mainly effectiveness reviews. And while that might be slightly work better with clinical reviews, with public health that's quite difficult, because what you want to know is not just whether something is effective, and also with other social development reviews, but why and how. So there's the paper which Howard White has written on theory-based impact evaluations, which was quite useful in terms of talking of how what he's already said about sort of nesting this effectiveness evaluation within the broader causal chain and trying to look at assumptions between each link and then trying to understand the process as well. So while that sort of extends the evaluation, but it can be much more useful in terms of understanding the process. And with NGOs, I think Howard has already talked quite a bit about the sort of variation in the quality of the evaluations which exist.
Right, I want to thank everyone for coming. We have lunch served afterwards, so just I think we served Priya, is that right? Just out in the hall, okay. And I really want to thank our presenters. Thank you very much, 3IE, for coming, and Ruhi, thank you as well for coming on behalf of the Cochrane Satellite Office. I'll just try to be brief in trying to sum up at least some of the key points that I took away from the day. Hugh started off with the presentation on water supply and sanitation. And in terms of the 3IE methodology which is based on the Cochrane and Campbell methodologies, one of the points he touched on was the search. So the search for evidence and the thoroughness that needs to go into it and the transparency that needs to go into the search. So I had a look at some of the 3IE evaluations that are published online, and I think there's about 22 online right now. And what's really nice is there's a very clear protocol. that's published that shows this is the criteria that we're using for our search. And I think that part of the process and then the thoroughness that falls from it is a necessary starting point. And a key point that also came up for me is that, the importance of looking at unpublished papers as well. Now, there's a potential trade-off there because published papers have been through a peer review, but there's also, it was mentioned, a publication bias. So the way you get published in economics journals often is if you're showing a significant effect size. Okay, so if you're just pulling from published articles, you may be overstating the effectiveness of certain types of interventions. And so I thought that was something that was very interesting. He also began to get into the statistical meta-analysis and the processes for how this is done. And to get a sense of the average treatment effect for different types of evaluations. And so, for me, one thing I'm going to do when I go back is go back and look a little bit at odds ratios and risk ratios so I can understand that better. But I think it is very interesting that you can pool across different types of interventions. And what that can tell you. So in the case of the supply and sanitation, water supply and sanitation, the different categories they had, they basically said that, of these studies that they pulled, that water supply didn't seem to be effective, that the pooled kind of treatment effect was not statistically significant. There was no effect. So that's not a sense that you stop doing these types of interventions, but I think as policymakers or practitioners, it's best to then look into what those interventions were, what might be common across them, and then how your intervention might be different. As opposed to water hygiene, or water quality and hygiene, which did show kind of, on average, these pooled significant effects. Next was the presentation on farmer field schools that was done by Birte. And here she touched on the causal chain analysis, and I thought that was very interesting. So instead of just looking at farmer field schools and just jumping to the outcome, the final impact variable that we might care about, which might be yields or might be increased revenue, they looked at different steps along the way of the causal chain. So one of the first steps they looked at was there a change of knowledge? And if there was a change of knowledge in terms of good, improved farming practices, then was there a change of behavior? And by the systematic review, then looking at kind of each step along the way, I think that's a very good practice. And I imagine why Howard would think that would take an additional 6 months to do from the 18 months from just an effectiveness review. And what was also interesting is, and I think that you can see, we're talking about effect sizes. And we're giving a numerical value to these effect sizes. And so that is, in a way, you could say, is privileging quantitative research, this whole method of kind of looking across, doing a meta-analysis. So I thought was interesting here was then, okay, so then how can we bring in some of the qualitative literature? And Howard touched on a little bit about their philosophy for how their systems for doing that. And I thought that was something that was very interesting. So then that allowed her to talk a little bit about what are the accelerators and what are the barriers she thought from that qualitative research. And you could maybe not criticize, but you can kind of question the connection between the qualitative research to the quantitative numbers because it's not coming from the same study, but Howard also explained that there's good reasons why that is. And so I think that's methodologically a kind of an interesting innovation and an interesting practice to consider. Now, Howard always gave a very interesting presentation on education, and particularly looking at outcomes related to attendance, dropouts, and participation. And for me, I particularly liked this beginning session that looked at like the limitations of this goal scoring approach. So kind of, if you're basically throwing out different interventions in your review because they're not showing statistically significant effect, is that kind of the right thing to do? Is there some consistency there if you kind of pool this information together? And this is different, so I would encourage you, there are literature reviews that JPAL does, not systematic reviews. And I think outside there's a list of the different literature reviews that we do. I suspect that we are taking more of this approach. Our researchers are taking more of this approach. It's not nearly as systematic, but what they're doing is kind of specifically looking at randomized control trials It's professors who are working in these areas and trying to make the sense of the evidence themselves. And we actually don't take a meta-analysis approach. We're looking at individual studies of significance and then trying to extrapolate what the lessons are. And I think that that's always the challenge, is that how much when you go from the primary data to the extrapolation, how do you know that that's done in a rigorous way? So do you trust the way in which that's been done? And I think what's nice about the approach that I've learned about today is that you're kind of looking a little bit more at this meta-analysis on data. I still think there's a lot of value to the literature reviews that we do, but it is fundamentally a different type of exercise of a meta-analysis. And it's also, and I think another point that Howard brought up earlier, which is very important, is efficacy evaluations versus effectiveness evaluations. And so that is something that USAID kind of looks into as well, is that efficacy at some sense, it's proof of concept. And what you really need to look at is that, as Howard mentioned, there's a lot of additional monitoring that's done by the implementation organization, sometimes also done by the evaluation organization. So you could kind of imagine that would be a higher band of effectiveness. So the way USAID does it is that they want in their development innovations ventures in stage 2, they want to see measurement impact at scale and how much of that holds. I think that's a very important distinction to make when we're looking at the results of randomized control trials. And Ruhi, thank you very much for giving us a history on the Cochrane collaboration. And specifically, I think it's very good that the satellite office is being set up in Manipur. And it would be really interesting to see, it's a challenge I know that Global Development Network has faced, a challenge that we faced at JPAL, is how to build interest and do capacity building for in the sense of JPAL, is for randomized control trials amongst locally based researchers. I think here for systematic reviews, it's a key challenge, and I'd be really interested to see the progress that you make in those areas. And also see if the questions that people point to, the way we want systematic reviews, how those are different than kind of what the global literature shows. So it'd be really interesting to see how this progresses. So taking a big kind of step back, I think this is, systematic reviews are kind of a way that we are trying to take a step towards evidence-based policymaking. And there's, I think, a lot of caveats in this, and there's a lot of, as Howard was also touching on, is that when you see the debates around the results agenda, there's often kind of on both sides or the multiple sides kind of a beating up of straw men. So I think it's what we're saying, or what the presenters here have been saying, is that if you see there's a systematic review that shows that there's effectiveness of programs to promote water quality, it doesn't mean that any programming you're going to be doing in this area is going to lead to effective. And it's such a result, such a simplistic kind of frame for understanding the role of evidence in policymaking is kind of thoroughly unhelpful. And so I think this is something, systematic reviews are one way. One of the things that JPAL has been doing is by trying to do replications of original studies. So having a study that, say it's a study, an asset transfer program that Brock has done in Bangladesh, taking the same type of program and replicating it, say, in the context of West Bengal or Pakistan or Honduras or Ethiopia and Yemen, which has been done under this graduation initiative set up by IPA, and then seeing kind of how, if those results hold in different contexts and how the results kind of might differ, thinking about the causal chain. These types of things are kind of how you begin to connect one study to a generalizable policy lesson. And it's a process. And systematic reviews are a very different way but something towards the same end. And so I think it's important to kind of see these as a starting point for evidence-based policymaking. It's just like when Howard was overcoming his knee surgery, he just didn't read the Cochrane review and then decide, I'm not going to do physical therapy. He kind of looked into, what were the take-ups in the original study, And maybe that is an effectiveness study, but if I'm disciplined enough to do this 6 times a day, maybe it have a positive impact on me. So I think there needs to be a lot of kind of consumption behind the results and not just taking the results and extrapolating too broadly from them. And I think the critiques around evidence-based policy making or around systematic review are also worth keeping in mind. I mean, we heard some of them today. One is, how do you meaningfully integrate qualitative evidence? And it's much more difficult to do because it's much more difficult to aggregate. And we heard some ideas about how that can be done. I think another is, that all of this, any intervention takes place in a particular context. And many of the presenters emphasized that today. And thinking about political, institutional, and social context when you're thinking about the generalizability of data is as relevant for quantitative studies as it is for qualitative studies. And I think another one is, we got into a little bit about the process in terms of mapping the causal chain of how inputs kind of lead to impact. Another thing that I know it's now an increased focus of the World Bank is, we also don't know how well these different programs, we have a sense of how they were designed, but we don't always have a sense when we're doing these types of reviews of how well they were implemented. And that, I mean, that is going to be a limitation, is implementation quality and the replicability of implementation quality. And I think it's something to bear in mind, but it's also something that, that all types of evaluations and all types of kind of research, when you look at the generalizability of studies, also face. So that's it in terms of a rambling summary from me about what I got out of today. One thing I want to announce on behalf of Clear South Asia and JPAL is that we have our executive education training on randomized control trials, implementing randomized control trials from July 8th to July 12th. So if you would like to, we have more applicants than spaces already, but we're going to be doing a formal review and picking applicants based on the criteria we have. So if you're interested, you can find Priya Arora's email address on the JPAL South Asia website, and you should email today and she'll send you the link to apply. Also keep a lookout for the 3IE Delhi seminar series. There's a couple of events coming up in June where researchers will be presenting their primary research studies. And I think if you contact 3IE, they can get you on a mailing list for those types of things. And I also just want to say thank you to the community of evaluators. The community of evaluators is a professional association of evaluators here in South Asia, and it was actually someone who's sitting on their strategic team that advised us to not only co-host this event with them, but also to reach out to 3IE, so special thanks to them. So without further ado, I'd like to wrap up. Thank you again very much for coming, and look forward to seeing you out for lunch just outside. Thank you.